Thank you very much, Dr. Wyllie. I would like to personally welcome all of you to this webinar. We're all excited at Cleveland Clinic Epilepsy Center to have the opportunity to be part of the webinar physician engagement series. And we would like to use this opportunity to share with you some of our more exciting medical and surgical epilepsy cases. And as you will see during the day, we have a set of faculty from the Epilepsy Center who will be participating in discussions. We would love to hear from you, to read from you, to get your comments, your feedback, and to make this exciting webinar opportunity a very interactive setting in which we share ideas, we learn from each other, and certainly we get to have much better opportunity to care for our patients with epilepsy. Without further ado, I would like to ask Dr. Wyllie to take over the moderating the first case here, presentation first case. We're going to have two cases this morning, one presented by Dr. Elaine Wyllie and the other one presented by Dr. William Bingaman. Dr. Wyllie?
Thank you, Dr. Najm. Our first case illustrates some of the epilepsy surgery challenges in young infants. Helen was completely healthy and a very bright and engaging little girl until at 11 months of age, she presented with new onset of seizures that occurred once or twice per day. She was such a delightful child, and her parents adored her. They were both medical professionals. This was a very difficult first presentation. Her seizures were visually induced. She would sit on the floor, as you see here, and stare at patterns on rugs and flooring, and she would have watering of her eyes and appear dazed and confused for 1 to 3 minutes with these seizures. As you can see, her EEG interictally showed sharp waves in bilateral temporoparietal and occipital regions, as well as polyspikes in the same area. At 12 months of age, an MRI was performed at a community hospital with somewhat limited sequences, but as you can see here, no clear abnormality emerged from that initial study. Her visually induced seizures persisted daily despite treatment with 2 antiepileptic medications, first levetiracetam and then topiramate, but still these continued, and at 15 months of age, she developed a new seizure type. It will be no surprise to this erudite audience that the seizure type was infantile spasms with hypsarrhythmia, and you can see there's been a tremendous difference in her EEG from just a couple of months. So her clinical and EEG features exploded into an entirely new phenotype. This brings us to our first audience response question. Non-localized patterns, such as infantile spasms and hypsarrhythmia, are a contraindication to epilepsy surgery regardless of findings on MRI and PET. Is this true or false? And while you are answering this online at your own office or home, I'd like to ask Dr. Ajay Gupta. You've done extensive research on this topic and have written at length on this. I'd like to know what you think about this and how you would visualize Helen at this point.
I have to say that by and large, the answer to this statement is false. We understand now that in many children and many infants who have focal epileptogenic lesion, regardless of its size, location, or etiology, that you could develop these progressive epileptiform abnormalities that appear generalized, diffuse, multi-regional, and you can develop this syndrome of infantile spasms and hypsarrhythmia. So, of course, this doesn't occur in everybody, but I think in this scenario, I think that this would qualify as a false statement. It is absolutely necessary that this child should be investigated for the possibility of epilepsy surgery.
And in retrospect, do you think that those initial spikes and polyspikes in the posterior quadrant bilaterally, could that have been a form of a pre-hypsarrhythmia sort of indication, something that hadn't yet fully evolved and yet was not focal to one local region either.
I think that's a very, very good insight that you bring into this. Many of these infants actually start with focal epileptiform abnormalities and actually focal seizures. And in fact, that window could be only a few weeks, few months, or it could be longer. And therefore, the best opportunity you have to really understand the localization of their epilepsy is early on. And if you miss that window by doing some routine tests and treating them like any other garden variety epilepsy, you might lose that opportunity and you develop this forest of fire, which sometimes can be very difficult to sort out, especially when you do not have access to the first EEGs or first abnormalities on the EEG.
And truly, when we looked at her seizures and the videos of her seizures, we thought they felt semiologically as if they were focal. And so we were wondering if perhaps this EEG was confusing the picture a little bit. Do you have any thoughts about why this developmental change in phenotype can occur in infants?
And that's a $1 million question that I think many people are trying to address with the bench research or with understanding the molecular mechanisms of epilepsy. And I know Dr. Najm also spent a lot of time looking at cortical dysplasias and how, what is the mechanism behind the epilepsy caused by this condition. But I think what we know is that this is really grounded in our observation and experience that this evolution of epilepsy does occur. It doesn't occur in every child, but it does occur, and people have hypothesized there could be genetic underpinnings in certain patients. There could be certain types of malformations that give them more risk of developing this picture, as well as there could be really underlying proteins or synaptic reorganization that lead to these patterns. But again, these are all, I think, at this point, hypotheses. We still, hopefully, will develop better tools to understand this phenomenon and therefore intervene early.
So Ajay, as or Dr. Gupta, so I'm an epilepsy surgeon, fairly simple epilepsy surgeon, I think, and I'd like to know for a case like this, which ones are surgical, which ones aren't surgical, right?
Yes.
Rather than assuming that it's a surgical case. What do you think the answer is? How do you know?
And that's where you need us. That's where you need epileptologists.
And that's why I'm bringing that point out.
Yes.
Behind every good epilepsy surgeon, there's 3 or 4 good pediatric neurologists.
That's right. And I think he highlights a very important point. It's really a teamwork between epileptologists, epilepsy surgeons, who have to go and dig down deeper. This is not to say that every child with spasms and hypsarrhythmia is a surgical candidate, but I think it is to say that in the absence of a good cause, or in the absence of a good etiology that you think is directly associated or causing the epilepsy, you have to look into this possibility. And therefore, it is very well known that many of the genetic epilepsies, many of the epilepsies that are caused by non-focal lesions can also develop this picture. So, therefore, you have to do both. You have to do diagnostic workup, therapeutic workup, always looking and re-questioning yourself if things are not going well. Am I missing an opportunity for intervening with epilepsy surgery?
Well, I think this is, I am an adult epileptologist and very honored to be with some of the best in the world, pediatric epileptologists and pediatric neurosurgeons. I've always been perplexed by an EEG that's so diffuse from a spike standpoint. And in my mind, always I've been asking all the same question that Dr. Bingaman is asking. Why is it happening like this? Now, I think, Bill, you may recall one of the patients we shared together maybe 2 years ago, when this person had generalized epileptic abnormalities, multifocal epileptic abnormalities, an adult person. And this is something in adults in the past, we never touched these type of patients. But what we found out in this particular patient, there was a lesion in the fusiform gyrus or the temporo-occipital junction, if you recall, when you implanted with a CEG depth electrode. And we found out that this particular area was an epileptic, the epileptic focus. Now, this opened up some ideas, probably in kids, but still I don't understand them very well, is the effect of connections. the network connections, the long and short fibers, but mainly long fiber connection between the interhemispheric fibers and interhemispheric fibers. So, but the question is back to you as pediatric epileptologist. Now, to me, if a patient is 1 or 2 years old, myelination is not very good. How can I explain such a synchronization in this kid? Still is a big question mark for us.
I think that's a very important point. I think myelination is part of the story. As you can see, this kind of diffuse features happen not in the early phase. In the first 2 to 3 months, you may still see focal. And when the myelination sets in, that's the time the brain is on fire. You have epileptic encephalopathy. And once the myelination is complete, again, they go back to a focal phenomena. I think the maturational changes in the brain, along with the lesion that happens early during the maturational phase, that's probably the perfect stage for this epileptic encephalopathy. And also, we may be underestimating the role of subcortical involvement.
Yes.
Many of these patients have large lesions, they may have subcortical. We know that subcortical injuries can make epileptic discharges more generalized. And as you said, genes, we don't understand some of these genes. I think age, subcortical injury, those are the 2 key factors.
So you'd all agree then
In my
that
opinion.
EEG is not so important in these patients, and more lesional MRIs and PET scans and things like that may be more important.
No, although I disagree. I think that EEG has a very, very important role because not only you understand the syndrome they're developing, not only you understand the evolution. Many times these patients and families will tell you, my child has 50 seizures and you find none, or vice versa. So I think EEG has an important role, but you have to ask right questions.
Yeah.
Correct, Dr. Wyllie? What do you
I was
think?
teasing a little bit.
And you can't, I think the key thing to remember, many of these children will have focal findings and they will match up with other features. But I think the important thing that we've learned, thank goodness, is that the generalized discharges, the diffuse pattern of hypsarrhythmia is not a contraindication to the possibility of surgery. That's the main thing. We shouldn't close the door on these children because their EEG is more diffuse, because of those issues that everybody has discussed. Dr. Moosa, you had something?
As I said, I think your question was, what should guide surgery in this patient? I think the presence of lesion is single most important thing when the EEG is not very helpful. And this is one situation. In general, in practice, we look for the most updated testing, right? Most recent video EEG, most recent EEG. In children like this, if you have an old EEG, that can be very helpful to focus on, that to look for. Because early EEGs could be much more focal. And as I told, between the 3 months to 2 years, the EEG could be poorly localized.
But so the question that comes here to mind, probably going back to this case, and when do we think, in cases like this, when the EEG is so diffuse and with this clinical picture, to pursue pre-surgical evaluation versus not to pursue it?
And that takes us right on in this case, actually. We'll share with you how we approach that, and everyone can help us understand if we did the right thing. We were also concerned that we were suspicious there might be a focal lesion we were missing, but we were also concerned not to miss a neurometabolic or genetic problem. So there was an extensive evaluation along those lines. We tried also to make sure there was no pyridoxine deficiency, and we pursued that, folinic acid. All of these bases were covered. And then we embarked on treatment directed at infantile spasms, ACTH, vigabatrin, benzodiazepines, valproate, etc. And yet, things still didn't go well. So we thought we need to continue at the same time that we were pursuing this medical side. We thought we did not want to lose the thread of the possibility of a lesion. So at 15 months of age, we repeated the MRI. And of course, those of you who work in pediatrics, you know that this is not a small decision because we have to do general anesthesia every time we want to take a look at the brain in this age group. So we decided it was important for this child. And at 15 months, we looked again. And this time, the study was done with more detailed sequencing and other sort of looks that we hadn't done at the community hospital. And what we were able to see, I think you will appreciate, let's look at this together. Sulcation and gray-white differentiation abnormalities in the right temporoparieto-occipital region there. There is a subtle difference between the right and left side, but the key word there is subtle. On T2 coronals, it was felt to be somewhat equivocal. The official reading was normal. Some other people looked at it and said, I'm not so sure. But we had definitely some concerns about that part of the brain. And this was more clear, probably, on the MP RAGE sequence, where you can see anatomically a difference between the right and the left side there in the back, and the temporal regions, parietal regions, and occipital regions. The sulcation is not quite the same on both sides. The arborization of the white matter is less clear and less distinct. Would my colleagues like to comment on this MRI at this point?
So I'd like to comment. I think that imaging a patient with epilepsy is probably one of the most important things that we can do at any age, and then interpreting it with someone who's got a lot of experience, obviously, in looking at these images, because the dysplasias, which are probably maybe 30 to 40% of what we see, can be very subtle. And very difficult to see, and really maybe only one person in your whole center might see it. But once it's pointed out, there are different ways to image it, and obviously we do a lot of other imaging studies other than MRI. But a good MRI sequence dedicated to epilepsy is important, and I think it's hard to do. We don't always do it here. We send a patient with epilepsy and we don't always get it. So the flares, the T2s, the coronal MP RAGEs studies are so important in the evaluation, because without a lesion, I think this case may not have progressed the way it did.
And it's always struck me throughout the years that the subtlety of the dysplasia bears no relationship to the severity of the epilepsy, and that it can even be invisible and discovered only microscopically. But once it's there, as Dr. Bingaman pointed out, you may not see, but once you see it, you can't back away. You have to take it seriously, even if it's subtle. Subtle doesn't mean unimportant. Yes. So we did a PET scan as well. And as you can see, there was global hypometabolism reflecting her hypsarrhythmia pattern and her entire epileptic situation. But in addition to that, superimposed was focal hypometabolism in the right occipital region, which corresponded to what we were seeing on MRI. So we had yet another convergent piece of evidence here to raise suspicions about a malformation of cortical development in that region. At 18 months of age, we recommended a right temporoparieto-occipital resection after extensive discussion at our epilepsy management conference. And I, in full disclosure, will mention that it was a divided opinion. There were individuals who were quite hesitant to offer such an extensive surgery in the setting of a very diffuse EEG pattern, a non-localized seizure semiology, and a rather subtle finding on the MRI. So there were some divided opinions, but the consensus opinion, after detailed informed consent with the family, was that we would recommend at Cleveland Clinic to proceed with the surgery because medicines simply were not working. And the family was justifiably hesitant. Always, it's very difficult for a parent to make such a big decision on behalf of an infant. And they sought a second opinion at another center, and the recommendation from them was no surgery. And that was based on the subtlety of the findings on the MRI. This led the family to pause and wait and see what would happen. At 20 months of age, this child had daily clusters of spasms, had failed to achieve seizure control despite 7 anti-epileptic drugs, the ketogenic diet, pyridoxine, folinic acid, and in addition, there was the onset of a new seizure type. Yet again, further evolution in the clinical and EEG picture. It started with a spasm, and then staring, decreased responsiveness, and evolution to bilateral clonic seizure lasting several minutes. So yet more severity to her clinical seizure picture. And she also had an epileptic encephalopathy. It was heartbreaking to watch this unfold right in front of our eyes. I was seeing this child every few weeks through this period, and I watched her progress from the initial visit of a bright, developmentally appropriate child to a truly devastated little girl. She had developmental regression, ataxia, frequent falls. She had to wear a helmet. She often came in with facial bruises and black eyes, abrasions. At 20 months, she was completely nonverbal, irritable, withdrawn, no eye contact, no social interaction. At this point, we talked about performing a third MRI and doing anesthesia. We were running out of options. We did, and this brings up question number 2. Serial MRIs may reveal subtle focal cortical dysplasia over time as the brain matures during early childhood. Is this true or false? And at this point, I'd like to hear from Dr. Moosa some thoughts about whether
Should I tell the answer now before the audience responds?
I think we should give your answer.
Okay.
And meanwhile,
Make them work.
you may or may not agree with our team. Who knows?
Okay. The answer is the serial MRIs can reveal lesions, may make the lesions more obvious over time. So the answer is true. Okay.
And let's see, I guess we agree. It lit up in yellow. Thank you, Dr. Moosa.
Okay. So as you know, when babies are born, if you look at the T2 weighted images, they are completely white out because the myelin is not there, almost not there, at least in the subcortical white matter. And over the next 1 or 2 years, it becomes progressively dark. So an early brain MRI has a nice good contrast because T2 is bright white matter. Sometimes the lesions may be obvious in a young, very early MRI.
What's the best way to image the 3-month-old brain? Would you say? What
Under
sequence? What sequence do you use to bring that differentiation out?
So we usually do the T1 and T2
Yeah.
without doing a flare. Flare is
flare's not useful.
unhelpful in the young
So
children.
fast T2 is good, I think,
Yeah,
right?
fast T2. So if you have an early MRI, definitely we should take a more careful look at it. But between these 3 months to 12 months or 1.5 years, it becomes very difficult to identify subtle lesions. If it is obvious, big, large lesions, easy to recognize. But over time, if it's a small lesion, serial imaging may make the lesion more obvious because the background contrast changes. So subtle lesions will pop up. They were there, but they were hidden in a sea of unmyelinated white matter. Once the white matter myelinates, it becomes more obvious. Does that answer your question?
Absolutely. And these developmental changes are, when we're dealing with infants, we have to constantly be aware of the developmental biology, how their brain is developing, how that affects our MRI, how that affects our EEG, our neurophysiology, our seizure semiology. We have a rolling, evolving organism that we're working with, and we must keep that in mind at all times. Yeah. And actually, as Dr. Moosa pointed out, there's been some research on serial MRI imaging in children. And as you can see here, this is an example of an infant where the MRI showed nothing exciting at 6 months. The same brain imaged at 36 months was very different. And you could clearly see a right frontal malformation of cortical development at that point with abnormal gray-white differentiation clearly standing out now. And this has been noted many times. Occasionally, not as often, but occasionally, malformations become a little less apparent at certain points of development. So it's very critical to be watching these MRIs over time if we're looking at subtle lesions. And so sometimes we simply have to make that decision. Another general anesthesia is required in this devastating situation.
And if I could just comment, so I think also it's, as I said earlier, it's very important to have somebody with experience look at these, because when we go back with the retrospectoscope, which is always easier to use, we often see these malformations even on the earlier studies. And so I think it's critical. The more eyes that look at these, the better.
And the other aspect is in very young infants, now that everybody, at least majority of the world, has the capacity to do an MRI very early, these lesions can appear very atypical that compared to the adult brain. So you could have a dysplasia that could appear hypo-intense on a T2 and a T1 image, which will then disappear and then reappear as a hyper-intense lesion. So I think if you're not used to that concept, you might not think that as a lesion. So I think so the signal characteristics, again, are very important. And like Dr. Bingaman said, you need to have an expert neuroradiologist at least interpret some of these difficult studies.
Gupta was among the many people who have said that we see what we know. And if one is very sensitized to these subtle malformations and their patterns and their evolution across age, and plus if you have a high suspicion of where you're looking and where the problem might be, that's when you have the greatest likelihood of identifying the lesion. I think we would, and we're so privileged that in my group, I feel so honored to be surrounded by brilliant colleagues who can help me find these subtle lesions. Otherwise, we would not be able to do what we do. Dr. Najm, any comments?
Well, I would like to comment from the basic mechanism aspect. And this is an area, obviously, focal cortical dysplasia, that is of interest of mine. And I've been working on this and been very lucky to have access to brain tissue resected by Dr. Bingaman since 1997. We're looking at those. And the idea in the beginning was that cortical dysplasias are very static, which is not the case, it seems like, from our studies on human brain tissue and animal models of cortical dysplasia. What we see actually, and this is something we described, part of the evolution or the duration of epilepsy. You take a lesion, cortical dysplasia, various duration of epilepsy, and you look at formation of new synapses. You see significant increase in new synapse formation with longer duration of epilepsy. Tissue resected at various time points from different patients, obviously, which is the same thing that is seen in animals. The point I'm trying to make here in regarding to changes in imaging characteristic of this, I'm not surprised anymore, because we do have completely new architectural organization or disorganization that happen with time, it seems like, within these cortical dysplasia, that may be the explanation or one of the explanation why we see some changes in the MRI with time. And that's why, based on, if I want to put my basic scientist hat now and try to answer this question, I would say absolutely. We need to do more imaging in these patients where we're not sure. Or in these cases, it is rightfully the case for a family not sure, getting two different opinions. Are we sure of this abnormality? We have issues, obviously, for infants and young kids where we have to do anesthesia, but considering how many seizures this patient's been having on a daily basis, what Dr. Wyllie mentioned, which is very scary, this regression, not only in the development, but regression every milestone they have. We have to do something about them. And to me, it is very logical to do multiple and serial imaging of these patients till we find out something, as Dr. Bingaman was mentioning, something that more than set of eyes will agree on. And hopefully we'll take it back to what we know about the patient. Going back to this patient, Dr. Wyllie, visual reflexive seizures. Does it tell us about localization here? I'm not talking about lateralization here, but doesn't it point to posterior cortex, either association cortex or occipital cortex, visual cortex? Second thing, the P7, T7, T8, P8 that you saw in the beginning, the polyspikes and spikes. Even though they evolved into hypsarrhythmia, as Dr. Naduvil was mentioning, this may be very precious piece of information to put it in context. And the suspected lesion that you showed, it is in the right temporoparietal area, which is very well-known lesion now for us when we are doing, even in adults, showing bilateral mirror image left and right temporoparietal. It is localizing this type of information. It's not lateralizing except the MRI and the PET scan. So to me, I think we have a good story to tell and a good hypothesis that would fit into that particular thing. But we learn. We need to see something, and we need to be sure about, as epileptologist and epilepsy surgeon, to do it. That's why serial imaging will be good.
Thank you for these astute comments. You've been so on the mark with this case, certainly. And just to tie up this point, there has been research. The MRI yield may double, actually, on serial imaging in infancy. And in one study of 51 children with focal cortical dysplasia and infantile spasms, the MRI was positive before 12 months in only 41% of the children. But after 12 months, it was positive in 88%. So we really have to remember that this is a known problem, that one MRI may not be enough. Another factor in detection is technique, as has already been mentioned. Question number 3, which MRI sequence is more useful for detection of focal cortical dysplasia in infants?
What age?
Infants.
What's an infant defined as? 0 to
12. So your
12
question,
months? 0 to 12 years? Months?
I think most people would use,
So the first year of
strict
life.
definition is less than 1 year.
First year of life.
I think for a neurologist, it's 1 to less than 3 years is.
I think we're looking at how long it takes to myelinate. You know, it's directly related to
2 years.
myelination, so obviously it's especially pronounced in the first year, but because that's, you know, connectivity is the big story in the first year. Myelination, synaptogenesis, axonal growth, and connectivity, that's the big thing. Then apoptosis comes in as more important, but obviously this is going to be an ongoing issue. So I'm sure you all remember Dr. Moosa gave us the answer before. It was T2.
Yeah.
And do you want to refresh everybody's thoughts about the water relationship with and how that works?
Actually, practically speaking, if you ask any adult neurology or neurology trainee or experienced neurologist, if they had to look at one sequence to look for the lesion immediately, they'll go for the flare sequence. Because if it's a bright lesion, it will brighten up easily. But in young infants, this could be very misleading, because the flare sequence in infancy, in less than 18 months, even up to 2 years of age, can what we call the subcortical unmyelinated white matter can look very bright, and it could be potentially misleading. If somebody is not familiar with that, they may see a lot of lesions, or a leukodystrophy kind of diagnosis may come up if they are not familiar. In fact, our neuroradiologist, Dr. Ruggeri's pet peeve is not to do flare in less than 18 months of age. And some people would be very cautious interpreting even a flare that is done before 2 years.
I think his exact word is worthless.
It's
Flare,
worthless. Don't do it.
infancy, worthless. Yeah.
Don't do it. If you've done it, don't look at it. If you look at it, if you find something, be cautious.
18 months or less.
Yes.
18 months.
So the T2 becomes much more important to us in that age range.
So when the nurses in the operating room tell me to stop acting like an infant, I can say that I'm not an infant, right? You guys say 2
This
years
is
of
a
age.
consensus definition.
Acting like an infant's different.
Is this chronological
Right,
definition
right, right.
or is it?
All right, I'm happy now.
So with all these thoughts in mind, to build a greater sense of confidence, we repeated the MRI at 22 months, and the malformation now is quite incontrovertible. I think you will appreciate the abnormality here, and it's becoming much more obvious.
If I may interrupt, go to the previous slide. Again, I think just to illustrate that point, this is 22 months flare sequence. If you see the frontal lobe, you can see that the white matter is even brighter. It may be misleading. If you look at the T2-weighted, the gray-white junction is pretty crispier. So even this one is a borderline for a flare. And obviously, you see much more brightness in the right posterior, but you have to rely more on the T2-weighted image in this patient than the flare, even at this age.
And also, we're showing you one slice from each different sequences. It's hard to judge the extent of the abnormality.
And that's why I'm going to bring you more slices in a
so
second.
Dr. Wyllie
But
Stoodley.
I like what Dr. Moosa has just said, because as we all know, these changes in the brain occur from a rostrocaudal direction. So sometimes we'll catch a period where we see better delineation of myelin and gray-white differentiation in the back of the brain before we see it in the front of the brain. And this baby is actually probably demonstrating that to us right now. As in other words, this process hit the back of the head, everything went crazy, and it's still progressing forward as we watch. And if you look at the MP RAGE, you can see the anatomy of that abnormality is perhaps a little bit more clear. Do you like that, Dr. Bingaman?
Well, again, you still have the posterior head. So I, as a neurosurgeon, would be saying, okay, well, you're at the temporal, parietal, and occipital lobe. What's going on more anteriorly below the sylvian fissure? And you can see that now Dr. Wyllie has brought in some pictures where both mesial temporal lobes are a little hyper-intense there. And that's probably an artifact through that region. So I think you have to have a little more imaging. And actually on one of the earlier MRIs, you saw what Paul would call a dirty temporal lobe, where the pole was blurred and the white matter just wasn't as crisp. So I would suspect that this is a more extensive malformation that goes beyond just that posterior temporal occipital region.
So, Dr. Bingaman, this brings us to your neurosurgical consultation. Of course, at this point, we asked the family to meet with you again. They had discussed surgery and declined, but everything was going wrong with this case. We were not making any medical headway. So please tell us, how did you counsel the family at this point?
Well, so I think the families with children come when children are regressing developmentally, despite 3, 4, 5 different medicines, ketogenic diet, sometimes VNS, many different therapies that are less scary than removing a portion of the child's brain. They come when they have a child who wants to drive. That's a big one in our society. And then young women come when they want to stop medicines and have babies. And so for this child, she's wearing a helmet, she's falling, she's regressing. Children fall and they hit their heads. And so it's not hard, if there's a surgical option, it's not hard to get them kind of on the same page. In fact, it's often hard to slow them down. You know, they're willing to kind of lay their child down in the consultation room. And so you have, but so from a surgical point of view, I think you think about how much tissue has to come out. And in general, I'm a believer from my experience that the more that comes out, the better. And I think that philosophy may be changing a little bit with our SEG technique, where we are looking at maybe smaller resections in larger malformations. But in general, for something like this, removing the most apparent abnormality is going to give the child a field cut, most likely a hemianopsia. It's in the language dominance probably isn't established, but it should be in the non-dominant or non-language side of the brain. And so removing the temporal portion of the parietal, some of the occipital lobe, is going to, I think, give us the biggest bang for our buck. We want to stop this child's epilepsy and get her back on the course to development. So thinking something like that surgically, you tell the family about the visual field loss, and if it's a hemianopsia, that it's going to prevent them from driving, which is not their concern now, but eventually will be. And they want to know, will my child survive surgery? What will my child be like after surgery? And I don't know, I know the answers that I've not had a death from a resection like this. So I think the chances of surviving surgery are pretty good, depending on the body weight.
12 kilos.
12 kilos, so it's a decent body weight. And so I feel confident. It's a team approach. We have excellent pediatric anesthesiologists, pediatric ICU people that help us, nurses, techs, everything. What they're going to be like is they're going to be, the best chance is going to be if we stop their seizures. And that's what the goal of surgery is. If we don't stop their seizures, we know what we're going to get. And we really want to do that within 5 years of onset, if we can, because I think there is some evidence. Dr. Ajay's published some nice papers looking at length from our center, looking at length of duration of seizures and outcome. And so I think that's pretty much what I tell them. And then I'm going to get their child, navigate them through surgery safely.
Dr. Gupta, if this were your patient and the mother said, what is my chance that my child would be seizure-free with or without medicines after surgery, what percentage range would you quote this child?
Like Dr. Bingaman said, if complete resection is safe and possible, I think you could give this family an odds of about 70% chance that this child will be seizure-free, or 75 to 90% better. And then approximately 2 in 3 chances that down the road, maybe about 6 to 12 months after the surgery, if seizures are not there, then maybe a chance to either reduce or completely wean off the anti-epileptic medications. And of course, you have to see the other side, which is the medical side, that what are the odds of us, our ability to deliver the same outcome, which I think is no more than 5 or 10% at this point.
Absolutely. So I like to remind families, and I know you all do as well, that there are risks to surgery, but there are also risks to no surgery. And in a situation like this, the risk to not operating exceeds the risk to surgery by a very large margin. And the other thing that we often talk about with our families is the expected complications and unexpected complications. Expected complications, as Dr. Bingaman mentioned, are limited to homonymous hemianopia. Unexpected complications, I know that Dr. Bingaman is always fully transparent about the possibility of death intraoperatively, low, the possibility of bleeding, infection, stroke, all of those issues, but they are low and, again, counterbalanced. If you think about this child 50 years from now, the SUDEP risk, the sudden unexpected death in epilepsy risk, the risk of death to trauma from these constant falls, anything else that might come in, it's counterbalanced pretty heavily The surgery risks, unexpected surgery risks, are lower than the cumulative lifetime risk of this severe epilepsy by a large margin. That said, it's always difficult for families to make a decision to subject their child to surgery. And I know we all try to be very empathetic to that because there is no harder thing to do. And that's when sometimes it's helpful to hook our families up to talk to other families who've been through this and are on the other side of it. And so we have a network of very dedicated volunteers who help us with that. So this family was ready to move ahead with surgery, and Dr. Bingaman performed this temporoparieto-occipital resection at 23 months of age early in 2014. And it gives me great joy to talk about the outcome. This was the histopathology. Cortical dysplasia was classified as type 1C, architectural disorganization, both horizontal and vertical. Dr. Najm, you've done so much research on cortical dysplasia. Would you like to comment on this finding, please?
Yes, I mean, this is a low magnification views of two sections where they do illustrate. I don't know how well you're going to be seeing those in your computer screens, but the one on the left where it's labeled as horizontal, it does show before that, let me just mention one thing. The top part of this section is layer 1, or the surface of the cortex, and you go deeper here. You're supposed to go deeper into the various 6 layers of the neocortex. Now, one thing in general, when we look at the histological section of a brain, at a low magnification, we like to see the layering organization. We like to see some layers, 4, 5, 6, if we can identify this. The first thing that strikes me looking at this on the left-hand side is maybe we see something on top, one layer on top, but below that is just almost very homogeneous field, no layer at the horizontal level. Now, if we go look probably closer at this thing, you'll see that these neurons assume various positions at the horizontal level, and this would qualify the new revised International League Against Epilepsy classification that was revised recently as what we call horizontal dyslamination. Now, on the right-hand side, you see a little bit close-up picture of maybe another section of this particular cortex, where you see some columns of neurons stacked up, but these columns of neurons stacking up, they don't make it from the deeper layers all the way up to the top. There are clusters of vertically oriented neurons or stacked up neurons that are disjointed from other columns. And this what qualify what we call vertical disorganization or various clustering of these neurons. Now, if we had only the left-hand side, only horizontal disorganization with no vertical clustering, this would have qualified for type 1A focal cortical dysplasia. If we had the vertical disorganization without the horizontal disorganization, it would have qualified for FCD type 1B. When we have both of them, it does qualify for FCD type 1C. As a matter of fact, for all practical purposes, the most common finding whenever it is as clear as this is type 1C.
Thank you, Dr. Najm. So we have confirmed our hypothesis, MRI and pathology, that this was the epileptogenic lesion that was there. And fortunately, we were so gratified by the outcome. There have been no seizures since surgery. As you can see, we've moved along a ways here. The postoperative EEG showed no spikes, no epileptiform discharges whatsoever, and she resumed developmental progression. And she's making excellent progress. She's become herself again and gained her personality. This takes us back to question number 4, our last question. At 1 year after resective epilepsy surgery, factors favorable for consideration of medication withdrawal include no postoperative seizures, no epileptiform discharges on EEG, no mitigating factors suggesting incomplete resection, or all of the above. Dr. Gupta, I'd like to ask you what you think about this case and how you would counsel the family about coming off of antiepileptic medications, yes or no, and if so, when?
I would like to see all the factors 1, 2, and 3. So therefore, my answer is all of the above. I like to see no seizures, no discharges on EEG, and of course, confirming with Dr. Bingaman that we have done a complete resection. I think that this child is maybe about a year from the surgery. You said 2014?
Early 2014,
Yeah.
so we're actually further.
Further away, okay, good. Our experience says, especially from the hemispherectomy series that we did with Dr. Moosa spearheaded, that you can expect seizure freedom in about 2 out of 3 kids. And I think that has been replicated in a larger cohort in Europe, where some of the countries maintain these big databases, like a Dutch collaborative study, or a European database where they're doing this trial called TTS, or time to stop anti-epileptic drugs. They have exactly similar findings have been shown that about 55 to 60% children after a successful epilepsy surgery are weaned off medications beginning somewhere from 6 to 12 months after the surgery, depending on physician's choice, which is, I think, a great evidence to suggest that if we do proper selection 2 out of 3 times, that can occur. The other thing which has come out of these studies is also very encouraging, that many of these children are on 3 or 4 drugs like this child. So for every anti-epileptic reduced or weaned, the gain in IQ point can raise from anywhere from 4 to 5, which is not small. If you're on 3 or 4 drugs, that means 50 to 20 IQ point. So I think, of course, these are retrospective studies, they're not very well controlled, but I think the momentum, the data is good enough to now recommend that this child is a good candidate for weaning anti-epileptic medication, of course, one by one, and eventually all of them.
Ajay, may I ask you a question here? As an adult epileptologist, we are a little bit more conservative in stopping medications. And I have to say, we don't have enough data one way or another. But when you say you would like to see all of the above, now, what if I tell you hypothetically that you're seeing 2 of the above?
Yes.
For example, patient who had no postoperative seizures, and I would like to have a follow-up question on that, but a patient whose EEG shows epileptic abnormalities. And would you apply same rules and say, well, I'm going to stop medication, I'm going to decrease them? And I like very much the rationale that you used and the data that you have to decrease and then stop medication. But would you stop it if you have one of these factors that is not satisfiable here?
That's a great question, and that's the gray area. So you have to individualize those big paradigms depending on each patient's situation. So if I see epileptiform discharges on the EEG, of course, that will be a word of caution, not to completely withdraw or wean the medications, but perhaps to begin and lower the burden, especially if we are not seeing any clinical seizures. And also, you have to remember that many times when you do a disconnective surgery or a functional hemispherectomy, you have to expect that that EEG will look as abnormal as it looked before surgery. Correct, Dr. Wyllie? Do you?
Next case.
Exactly.
Hold
Okay,
that
good,
thought.
good. So in other words, you have to put it in the perspective, and I would completely be very cautious in that scenario, Dr. Najm. And in fact, what these studies are also showing is it really doesn't matter when you start to wean medication. It essentially is that you can stratify these kids who are likely to fail and who are less likely to fail, and it doesn't matter whether you begin at 6 months or 12 months, who are to fail, they will fail. That's what is coming out. And as we get bigger numbers and strength, we'll learn more about it.
So for example, if you're operating on a child with tuberous sclerosis and you're trying to ameliorate the immediate seizure problem, even if the child is seizure-free, you're probably not going to go to no medicines. But in this child, to the best of our ability to determine, there's a single focal epileptogenic lesion which has been completely resected. In pediatrics, we almost are polar opposites in our concept about withdrawing medicines compared to our adult colleagues. We might even have the opposite opinion. Our default is to try to get them off. And as a matter of fact, so we start streamlining the medications if they're on several in high doses. We start streamlining at 3 months, 6 months. My goal is that if the child is doing well and I have a good feeling about things, I try to get them to moderate doses of one drug by 1 year. And then at that point, if it's this kind of a child, I'll try to get them off completely. And I would say that that's probably the way most pediatric people approach it. Dr. Moosa, would you like to comment?
I completely agree. Recently, we had a child who had seizures right from birth. By the time they came to us by 2 months, on 5 different seizure medications. We did initially posterior quadrant surgery, had some transient success and then had to go for hemispherectomy. You did this patient. It was 5 medications, 3-month-old. After hemispherectomy, I don't wait for 3 months.
Yes.
I started waiting from 1 month onwards.
Yes.
We cut it down. Right now, it's probably baby is around close to a year. Right now, only on 2 medications. So it all depends upon that particular patient and the burden of medications and the comfort level of. I know that hemispherectomy in Dr. Bingaman's hands is very good chances for success.
So you gave that child 15 IQ points on the long run already.
But
I think that's
yeah,
what the data say.
I think that's a very important point. These very sick infants who are essentially in status, they're often extremely sedated. And we try to, I think you're absolutely right, highlighting that you want to uncover that as quickly as possible. Sometimes they come in with phenobarb levels of 90 and things like this. Just, we have to roll that back as quickly as we can.
Very different than the adult patient that Dr. Najm sees, who's got 35, 40 years of epilepsy.
Yes.
And 19 different drugs.
And wants to drive and will not be able to, completely different psychology.
But this is, to me, as an adult epileptologist, when I said, this is the best or most important case to be made for early epilepsy surgery. Yes. It is just, I think, we see it every day. I mean, a kid who has such a big lesion with such a big surgery, being able to be completely seizure-free, and all of my colleagues here, the pediatric epileptologists, agreeing that absolutely we are comfortable stopping medication, and they have huge experience in it. I think you're making a good case that all epilepsy surgery should be happening in kids, not in adults, and I may have to change my focus.
There's been a tremendous improvement in the appreciation of this worldwide, thanks to many of the people who are here with us today. The word has gotten out that we need to move this down. And I think this case highlights several key points. In children with early focal brain lesions, EEG and seizures may be poorly localized for developmental reasons. The MRI in that case is key to surgical planning, and the findings of focal cortical dysplasia may be subtle so that serial imaging may be required. Thank you very much for your help with this case, and I'd like to pass the baton here to Dr. Bingaman.
Thank you. So the second case highlights a lot of what Dr. Wyllie so eloquently expressed in the first case. I would like to thank Dr. Wyllie for inviting me, Dr. Najm, Dr. Ponsky for inviting me to speak. We don't have quite as much time, I think, for the second case, so we want to stay on schedule because it's a full day. And this case talks really about what happens in those patients where seizures recur after hemispherectomy. And we're going to use Laurie. She had a difficult perinatal course, and unfortunately, at 3 months of age, noticed seizures. The family noticed seizures that were either left or bilateral infantile spasms. She also had some arrestive activity, and the family thought the eyes turned to the left. At 10 months of age, a mild left hemiparesis was noted, and it's always amazing to me as at the infant level how difficult it is to pick up hemiparesis, and even how difficult it is to pick up seizures. And parents often will come and feel guilty because this has been going on for almost 10 months a year, and sometimes it's all new to them as well. Developmental delay, not meeting milestones, and seizures daily. So in this child wasn't so subtle. 7 different anti-epileptic medications and pyridoxine, as Dr. Wyllie mentioned in the last case. EEG, which I can maybe ask Dr. Moosa, Dr. Naduvil to comment on if you'd like. It's pretty straightforward.
I think the EEG, the title says hypsarrhythmia. It's hypsarrhythmia. This is a bipolar montage. As you can see, left temporal at the top 4 chains, and the right temporal, left parasagittal, right parasagittal, and vertex at the bottom. And you can see abundant high amplitude spikes in the right and the left hemisphere. In fact, it looks slightly, the spiky components are more on the left hemisphere, maybe more on the posterior, but they are present bilaterally.
So you might say that there's a bilateral, more generalized, but maybe some predominance on the left?
Based on this EEG, this page, yes.
And is that helpful to localize a lesion?
We have to interpret with caution in young children. I heard the baby has left hemiparesis, right?
As a left hemiparesis.
Okay, I would expect the right hemisphere to be the injured hemisphere because of the structural
So you'd
problem.
like to see predominance on the right?
Well,
If
but
any.
you can see decrease on the right.
Yeah.
That's
So-
the other possibility, is that
so-
things are paradoxically higher.
So that's why you have to interpret in the context. It could be more epileptic activity on the left side or decreased on the right side because of the structural injury.
So there's something epileptic going on,
Absolutely.
but you may not be able to tell what hemisphere quite yet.
Whenever there is an asymmetric EEG finding, you should be cautious. It should be interpreted with everything together. You
Okay.
can't go only by the EEG.
All right.
That's the standard dictum.
So it doesn't surprise you.
And in adult or pediatric
So,
asymmetry.
so it's not a normal EEG,
Not normal.
and it's an epileptic EEG, correct?
Absolutely.
All right, we
Epileptic
got, see, now
encephalopathy.
we're getting somewhere.
Yeah.
Okay. How about this EEG?
Okay, this page,
Help you?
again, you can see it's not a hypserhythmic page. You can see runs of spikes in the right posterior, maximum in the P8 and O2 there. And you can see some spikes on the right frontal also, and a few on the left posterior.
And this is in
So-
deep sleep, it says on the bottom. Deep sleep.
Okay, so we are seeing more focal now on the right side. It depends upon the page. You have to see more pages.
So
Obviously.
now you're suspicious that maybe something more right-sided,
Yes,
with,
and-
especially with the left hemiparesis.
And if you look at the parasagittal, the F3C3, FP2, F4, F4C4, you can see maybe some less fast activity on the right side compared to the left side. So it could be maybe meaning that maybe there is more injury on the right side.
Correct. Okay.
Yeah.
Sevens, etc. Pyridoxine, abnormal EEG. Non-localized seizures. What does that mean?
So this is an ictal pattern. As you can see, I think people are familiar with the infantile spasm, the initial burst there with a fast activity riding over the delta slowing followed by diffuse attenuation. That's a EEG signature for epileptic spasms, maybe slightly more sustained, but this is
As a surgeon, when I hear non-localized, that bothers me. Maybe it shouldn't. I don't know. I never asked you. But should it bother me? No.
it's not just EEG, everything to be put together in the context. And in young children, it could be frequently non-localized. I think we overestimate the role of ictal EEG.
So you shouldn't see the non-localized EEG report and say there's obviously nothing here focal, right? You shouldn't do that in a young child.
Yeah, well, non-localized EEG could be still focal,
Yes.
but for, it could be interhemispheric onset
Deep.
with deep onset with a generalization of the changes that are very fast to occur. So we don't see the onset. So to me, it's not at all a contraindication to proceed with the hypothesis of focal epilepsy.
Dr. Wyllie, do you agree with, do they know what they're talking about?
They do.
They do. Okay. So,
Thank you.
It's a common
That means a lot to
pitfall.
us.
so as again, from a
Yeah,
neurosurgical
international
perspective, this
big-
is what I like to, I mean, I don't like to see this, but I like the imaging is important. And here, it's interesting, I think, and there is some subtlety to the imaging, believe it or not. Often the perinatal infarctions, especially with an MCA infarction, it can be variable from a small lesion in the corona radiata to a much bigger lesion, depending on what part of the MCA is infarcted. But you see on the monitor on your computer screen, sagittal imaging, a large area of encephalomalacia in the territory of the middle cerebral artery. You see it on the axial T2. And on the very far right on your screen, you very subtle abnormality in the left hemisphere, which is in the opposite hemisphere from the stroke. And this is an unusual finding. I don't know that I've seen too many middle cerebral artery infarctions, which is a thrombotic event, unilateral usually, with a contralateral MRI abnormality. So an interesting case that was identified again by, I think probably Dr. Ruggieri looking at this. And it throws a bit of a monkey wrench into this because for the unilateral imaging findings with a left hemiparesis and the EEG findings we saw maybe with a right-sided predominance, when Dr. Wyllie presents these patients to our group, because they all go through our patient management committee, Everybody thinks hemispherectomy with a hemiparesis and a lesion. The EEG had some left-sided findings, and now the imaging has some left-sided findings, which might make us pause. Would that?
No,
does this
it
make
does
any of you
not make me
nervous?
pause.
Doesn't make you
I am not
pause?
pausing because when we, obviously the overwhelming abnormality is the right MCA infarction. But when we went back and looked at the contralateral side in a research study, we found that there were abnormalities on the other side in 75% of the kids, and that the difference between their surgical success rate was independent of that. And then Dr. Moosa again confirmed that in the hemispherectomy series. We've looked at that a couple of times. Because these children have global anoxic events when they get these infarctions. And so some abnormality on the other side. And in addition, even with malformations, the malformations are not always only unilateral. But our question is, the MRI obviously is bilateral, extremely asymmetric, but bilateral. And so the question is the epileptogenicity bilateral? And that does not necessarily go together.
So you wouldn't pause?
I would not pause.
Anybody else pause?
Well, this is an important informed consent decision, especially if you cannot sort that out on a completely hypsorhythmic EEG, as in this case. This is our experience. Maybe we are better in selecting these patients, but there have been other series done in a larger group of patients where they think it does impact the outcome. So I think it's controversial, but I think it has to be laid on the table.
But
it has to be part of the informed
impact
consent.
the outcome is not the same as
Correct.
contraindicate surgery.
I totally agree with you.
So I think that's the key point,
Yes,
is we would have,
yes,
obviously this would have to be discussed very
Yes,
openly, and I
yes,
know that
yes,
you did.
yes,
I know you said there is this abnormality,
Yes.
the long-term outcome may be
Yes.
somewhat more guarded than
Yes,
otherwise, but in your child who's having such a
Correct,
catastrophic
correct.
situation.
Yeah, and remember, daily seizures, seven different
Exactly.
medicines.
You
So
should
you're-
never
you're-
withhold surgery, yet
stuck.
this should be an informed
But
consent.
what is the importance of seizure semiology here? Would you
Unhelpful.
unhelpful? Huh?
Spasms can have no focal
this point,
features. They can have focal features.
Now, what if I tell you, like in this particular case, I don't know, it is very focal. For example, it is a left hemibody focal motor seizure.
And of course, if
Would it help you more to make
and
an
I have
argument for
never
the-
seen
Yeah,
that.
you
In
haven't.
other words,
Okay,
that would be
okay.
I mean, it is possible, but when we've looked at our kids with these kind of lesions, if the jerking is stronger on the other side, it's usually because the hemiplegic side can't participate as much.
Okay.
So
It's interesting, though, after hemispherectomy, when the wires are cut
Uh-huh.
and the motor function's gone, the gross motor function that's preserved is probably at a deep level, or there's been some functional MRI studies looking at it on the other side. And the semiology can be the same. And after anatomic hemispherectomy, the semiology is still the same. So I think you have to be careful with everything, which is going to be one of the points. The PET scan, you can see, I think, kind of more the expected findings. You see a pretty significant hypometabolism in the right hemisphere. Perhaps some subtle hypometabolism on the left, but really not as apparent. And so expected findings. Patient management discussion, underwent a right disconnective hemispherectomy. For the audience, the most common terms in the literature are anatomic hemispherectomy, removal of a hemisphere, and functional hemispherectomy, coined really by Dr. Rasmussen back in the 70s. That has evolved into a number of different techniques because as surgeons we have very strong egos and we have to have techniques that we name. And so disconnective hemispherectomy is my name, and because it makes more sense to me. Functional hemispherectomy, we're not making the hemisphere more functional. We're maybe making the patient more functional. So a disconnective hemispherectomy, regardless of how you do it. And the patient did fine. No complications, no significant issues. On postoperative day 4, the parents noticed perhaps some unusual behavior, and it's my opinion that parents are always correct. Sometimes even when they're not, they're correct. And so I take things like this seriously and usually say, okay, I'll have our pediatric epileptologist come and see what they think. And it's not unusual to see some behaviors, especially with a new hemispherectomy patient who didn't have whose weakness is worse. The normal movements on the other side can often look epileptic. Eyes do funny things after hemispherectomy. So some uncommon. So we did what we do, and we got some EEG. Dr. Gupta, you're the expert
Well,
now.
I'm gonna
case. What are you going to think? What do you think?
Well, this looks now a clear asymmetry.
This is
post-
post-right hemispheric
correct.
disconnection.
So the right side obviously is flat. You can see some independent spikes. Again, I'm not surprised. You just did major disconnection, and there are some parts of cortical tissue still there. But what I'm still seeing is lots and lots of spikes on the left side. So now from hypsarrhythmia, you made it left hemihypsarrhythmia, right? Which is a little concerning, but I think still I have to be cautious in not over-interpreting it and not saying that you have failed surgery. I would like to know more.
So I would be a little concerned. To
Yes.
me, this tells me that one of two things.
Yes.
Either we were wrong and it's
Yes.
truly bilateral epileptogenicity,
Correct.
or we were not complete in our disconnection and there is still some epileptogenic tissue which is
Yes.
firing off across to the other side and activating this encephalopathic process over there. And I think that you can't answer that question on the EEG.
Correct.
Because you've taken away everything on the other side and you're not going to record that spot. You're simply not going to find that spot in the operated side which is causing the trouble based on scalp EEG. So obviously we're going to have to think about it in other ways.
We don't do a lot of EEG on 4-day post-op hemispherectomy patients, so I
Yes,
think it's
yes.
difficult to interpret. Dr. Naduvil, last
Yeah.
comment on this slide because we're
I've always
moving
wondered.
along.
Just assume that this patient had a successful hemispherectomy. If you had done a 4-day EEG on this patient who had a diffuse hypsarrhythmia, would the left side still be showing some spikes? Would it dwindle down? Or,
Yes.
has always been my question, is it an encephalopathy process will take some time
The
to,
running down
it's like a
phenomenon.
fire or
Correct.
smoke, takes
Correct.
time to dwindle down.
Yes.
So it's sometimes difficult to
And
interpret.
the
at
spikes
this
on the right
stage.
side don't
We
bother
don't
you,
know it.
right? The tissue's alive on
We
the
don't
right,
do
it's
the EEG.
disconnected. So you're going to see spiking, correct?
In fact, that running down phenomenon has been seen in epileptic encephalopathies like hypothalamic hamartoma, where the EEG doesn't suddenly become normal. It rolls down if there has to be a successful
So that
outcome.
may be the case.
Correct,
But
correct.
typically we do these in the kids because they're having
Correct.
seizures.
Correct.
Exactly.
So
Correct.
our sample size is skewed.
Yeah.
We had to
And
record
this
seizure.
doesn't necessarily correspond with the eye staring episodes, right? Okay. Dr. Naduvil, you know this.
Now you have
EEG.
the seizures.
What does that mean?
Obviously, this EEG
Failure.
is definitely concerning. As you can see, the left hemisphere is showing the ictal pattern. You see a high amplitude slow and a sharp transient followed by burst of fast activity in the left hemisphere.
What part of
Is
the
it?
left hemisphere?
It's more posterior, I'd see. As you can see, T7, P7, P7O1, P3O1.
So
Much
here's
more
the
posterior.
post-op imaging, and I think Dr. Naduvil actually helped with this slide. It's a very nice slide, I think, because as surgeons, again, it points to the abnormalities. So the regions of the hemisphere involved. Now, remember that abnormality is sort of left frontocentral, and so we see spiking now, or seizures now from the left hemisphere. Post-op day 4, right after surgery, things may be irritated, right? That's a common neurosurgical, not necessarily excuse, but an explanation for spells in the first week after surgery.
You didn't
But-
irritate that side.
I didn't irritate that
No,
side.
But
you did not.
If you recall, the pre-op ictal pattern is the same thing, but it's present on both sides.
Yes.
Now you're taking away the right
Yeah.
side. So that brings up, again, Dr. Wyllie raised
Yeah.
whether the independent seizures from the left side, did we get the side wrong?
Yeah.
Or-
And before
or is it a
surgery,
false
eyes
lateralizing
went
pattern?
to the left. These spells, eyes go to the right.
The one thing
Does that
I like
help?
to point out,
I wouldn't focus in on the eyes. I'd focus in on, I mean, the seizure is clearly visible on the left, but I think it's decreased on the right.
Well,
And
let me ask a question here. Sorry. How many seizures did we capture?
Several.
yeah.
All of
Several.
them.
But now, just to ask the question differently, what's the value of the P8 spike?
correct. I was going to say that because if you see
The right parietal
Before
spike.
everything else.
Yeah.
Yeah,
Yes,
so
yes.
but because I mean it could be coincidental.
Yes.
That's why I think I would like to see how many seizures we
Yes.
recorded
A few.
and was it
Maybe it-
stereotypical that P8? Because if that P8 spike is there, you can continue to think that it may be a right parietal onset and no big disconnection and then spreading to the side where you have tissue versus the other
So
side.
maybe a few
I
hypotheses.
think
So
that's
we
what
did-
I'll
we
pick
did-
up
and
on.
back.
we did look at it.
Yeah.
It was not consistent correlation.
It's not,
As you can
okay.
see in this page itself, at the 9th second, you can
Yes,
see
there
some
is one.
spike.
Yes, I see.
So it's an
this.
intraictal. We did not always see that proceeding right.
And
to
I
a
think
spike.
the point is, it doesn't matter. It can be there or not be there. This could still be spread
It's there here, right?
from the not completely disconnected
Right-sided
hemisphere.
seizures.
Yeah.
Yeah, that's what I'm.
If it's there, it could
Not
be
right, left-sided
suggestive, but
seizures.
it's usually not. We usually don't pick up anything on the other side.
Okay.
So the EEG,
Yeah.
different findings after surgery, it becomes clear the child's having seizures, which is not what we expect. And so question one, after hemispherectomy, lateralization of epileptiform discharges and EEG seizures to the non-operated side, rule out incomplete disconnection as the cause for seizure recurrence, true or false? In the interest of time, since we're running a little bit over, I'm going to tell you that the answer to the question number one is that lateralization of epileptiform discharges and EEG seizures to the non-operated side rule out incomplete disconnection as the cause, and that is false. It is very, it can be variable, but in the majority of these cases, we look at more than just the EEG and the MRI, and sometimes, as I think is going to come out, it's very difficult to know for sure in the cases of disconnective hemispherectomy. One of the questions is the hemispherectomy complete? And of course, if I did the surgery, they're always complete. That's what I try to sell anyway. It doesn't always work.
Yes, yes.
And you see here some representative pictures. And the little red square on the bottom left of your screen, I don't have a pointer, but you see that anterior line of disconnection where the basal frontal lobe gets disconnected is maybe a little bit too anterior. There's perhaps some tissue behind that in the posterior orbital frontal region that might still be connected. And my point is it's difficult to know for sure on one image. And so that answers question number two. MRI can be misleading after hemispherectomy. Don't trust the surgeon's opinion always.
So why so?
Because
we have
we have-
3T MRI, we can do
Yeah.
1 millimeter cuts. Why so?
Yeah, well, because of the postoperative, often there's postoperative changes. And I've seen cases where you absolutely see nothing, and you go in and you resect and you take out everything out that appeared to be disconnected, and the seizures stop.
So, Bill, is there a good time to do postoperative MRI?
I've stopped imaging though, because we don't do a lot of with the immediate images, other than make PowerPoint presentations. And so I think if there's a reason to image the child, we should, because as you said, they require anesthesia. It's a trip out of the ICU. They have ventriculostomies hanging and drains hanging out of their heads, and so unless there's a reason to do it, we don't do it.
Power drop in the hospital may have been.
And so welcome back for you, those just joining us.
Somebody's comment.
And so seizures persisted after hemispherectomy. Remember, this child has a very subtle abnormality in the quote normal hemisphere or the contralateral hemisphere to surgery, and had a right-sided disconnective hemispherectomy. The MRI was questionable. And so again, to patient management, and there's a discussion, and at the end of the day, is it ethical to not perform surgery when we don't know for sure? Surgery being a conversion of the disconnective procedure to the anatomic procedure, where at least the imaging becomes a little more clear cut. Anybody would disagree with conversion at this point?
Very fascinating, yes.
And again, this wasn't one spell after surgery, and in those cases, I think we are often will wait. This was pretty apparent daily spells are still persisting. You okay, Dr. Gupta?
I am okay. I'm just wondering, what is your explanation of you think you have disconnected,
Well, in
now
this
you're
case-
saying you actually have to remove the tissue?
Yeah, in this case, we go back to the imaging. Again, I think, and if I had a pointer, I'd be pointing to that area on the bottom left screen, on the sagittal, just behind that line of disconnection, where you see a little hyperintensity, back just in front of the hypothalamus. I think there's still probably a little bit of tissue there. It's a hard area to get to surgically. We get nervous when the hypothalamus is nearby.
I think our experience has been that it can be an extremely small nest of cells to cause an amazing amount of trouble in highly epileptogenic lesions. They don't look very apparent on MRI all the time.
Can you modify your technique in a way that the usual sites of disconnection? Can you do more tissue removal so that it's more obvious?
Yes, and I think it's an important point. So for patients who have malformations, it's important to remove the malformation and maybe disconnect the more normal appearance. But for a perinatal stroke, for Rasmussen's, for Sturge-Weber, I think disconnected works very well. Perinatal stroke is kind of designed for this procedure. We're going to skip question 3. We'll come back to it. This child was converted to an anatomic hemispherectomy. You see now the hemisphere is missing. On that side, there is some deep basal ganglia tissue left behind. Easier to say on this one that there's tissue, no residual tissue on the right hemisphere. And at 6 months post-op, with no seizures, the EEG, again, I don't read a whole lot of EEG, but I understand that you're more happy with this one.
Yes, this is what we call rebooting of the left hemisphere.
Rebooting. We just did that. Rebooting.
The spikes are completely gone, and you can see normal rhythms on the right side, on the left side.
Anything concerning here as far as, hey, let's stop some medicines?
We should think about stopping medicines after giving some time. We usually go by the 1-year rule.
Yeah.
It depends upon the number of medicines the child is on.
All right. We're not going to get into the conversation
But
because,
we,
again,
we
we're
should point
out
out
of
that
time.
slide has right-left confusion. It's normal rhythms on the left side, not operated. Decreased rhythms on the right.
Yeah.
Oh, yeah.
I told you I don't read EEG. So
Okay, that's a slide.
before surgery, after the first surgery, okay, right disconnective hemispherectomy, you see the right hemisphere is flat, seizures on the left. And after the second surgery, normal rhythms on the left hemisphere.
Yep.
Still flat on the right. The right hasn't done much.
Yep.
Disconnective hemispherectomy procedures. Rasmussen gets credit for the functional operation. Villemure coined the term peri-insular hemispherotomy. A month later, Johann Schramm coined the term hemispheric deafferentation, all disconnective with less tissue removal, hoping to avoid surgical complications like superficial cerebral hemosiderosis, which has been described after anatomic hemispherectomy, and blood loss, operative time complications. Very nice technique. Disconnecting the hemisphere essentially through the ventricular system. You can have a post-op image that looks like this one on the left side. The problem is that there's still tissue left behind. And so is it disconnective or not? You can see question number 4, all the different disconnective techniques, they do leave disconnective tissue behind, hoping to prevent hydrocephalus, which is more common after anatomic hemispherectomy. Outcomes are comparable amongst the various techniques. There's really not been a series to show a difference in outcomes, whether you do anatomic, functional, disconnective, etc. Disconnective is more likely to lead to reoperations. So all of the above. I like this question writer. I wish they would write for our board review test because questions are nice and straightforward.
Everybody gets an A.
Right, everybody gets it. Technical failures, it happens. In my career, and I'm about 350 into this, in the first 25, 30, I think that it's a surgeon error technique learning. There's a learning curve with this operation. Now I'm not so sure. I think the numbers are less than they were early in my career as far as recurrences. We've not been able to show an etiology statistically, but hemimegalencephaly and the more complicated malformations tend to have worse outcomes, especially with disconnection. In hemimegalencephaly, the anatomy is just not, it's not conducive to disconnecting it. And so we think about that. In this, and I apologize for the spelling typo, recurrent seizures after hemispherectomy, I looked at 289 of our patients recently. There were 45 recurrences, so 15% of patients. And not all of those are from here. Some of them come here after hemispherectomy. Usually a disconnective, not always. And the malformative cases of those 45, half were malformative cases, focal display or hemispheric dysplasias. or hemimegalencephalic patients. And the outcome is not, I mean, it's hard to argue. So clearly half the time they become seizure-free when you convert them. A quarter of the time they're somewhat better, and a quarter of the time they're no better. Important on the bottom is 23% of those patients got shunted. So the anatomic hemispherectomy absolutely puts the child at risk for VP shunting. Patients have to hear about it ahead of time.
Is it doing the same procedure you do, or you only do if it's necessary down the road?
It most often occurs in the first 6 months, but there's a child now who is 3 years after hemispherectomy, fell on the playground, hit his head, had headache, threw up twice, went to the local ER. They did a CT scan after their heart was restarted because they see a cavity, hemispherectomy CT.
Yes.
They realized, oh yeah, the child had hemispherectomy, but ventriculomegaly. So I get a phone call, hey, this child has to come up, he's got headache, but he had a headache because he fell and hit his head. So ventriculomegaly is very common, can happen most often the first year, but really up to years later. You got to follow these kids. You got to follow them.
I agree.
Wow.
So I think is this persistent seizures after disconnective hemispherectomy, video EG, MRI. You go to anatomic. If they're seizure-free, obviously the seizures were from that side. If the seizures remain after anatomic, they're from the opposite side, and you do what you can with medicines. And so it's a pretty easy algorithm at the end of the day to follow. And I'm really blessed again to work with you guys, Dr. Wyllie, and you started your career just a little bit before I did, and really was very interested in the hemispheric epilepsy. And so I've been blessed to be, it's my favorite operation because I think it's our most successful operation in epilepsy surgery. So.
Well, it's a privilege to have a surgeon of your stature and
appreciate
skill working for our
bless.
families.
So thanks to the audience. I know we ran over, and turn it over back to the moderator.
Thank you, Will. It's my pleasure to introduce the panel and the discussants for our next case. Dr. Dileep Nair, the head of our adult epilepsy section, Dr. Juan Bulacio, our epilepsy neurophysiologist, Dr. Jorge Gonzalez-Martinez, our epilepsy neurosurgeon, and Dr. Professor Patrick Chauvel, another one of our team members on epilepsy neurophysiology. Thank you. Dr. Nair will present, and Dr. Bulacio will start the first case, invasive evaluation for epilepsy surgery in lesional cases. Thank you.
Thank you. Go ahead, Juan.
Okay, so we're going to start with the first case, which is Mr. Johnson. So,
Lateral, yeah.
okay, here it is. Sorry. Okay, no disclosure for any of us. So, Mr. Johnson, onset of seizures at age of 16 years of age. These were episodes of bed waiting. So he took medication for these particular events until 19 years of age, and then he stopped. Then the seizures recur at 21 years of age. So those episodes consist of staring, decrease in responsiveness, hand automatism, and they can occur 3 times per day. The evolution, some of them could evolve into generalized tonic-clonic convulsions that were present 1 to 3 times every 3 months. He failed many or multiple anti-epileptic medications, and this is his scalp EEG, that as you can see here, this is a double banana montage. The channels on top are the left side, left temporal change. Then we have the right temporal change. Then we have the left parasagittal change. And then we have the right parasagittal change and midline. You can see this.
So Juan, if I could interrupt just a minute,
Yeah.
I think some things probably at this moment in time might be interesting just to highlight. One is maybe the nature of the seizure frequency, or the amount of seizures he's having, the non-generalized seizures he's having per day. He's having several per day, which is a little atypical for our adult population. And then this EEG pattern also, this interictal EEG pattern also kind of highlights a somewhat of a special situation for us in terms of what we think about in its localization aspects. So we don't have information that I would like to have, which would be something about his diurnal pattern. What are his seizures like? Are they more likely to occur during the day? Are they more likely to occur during night? I think these things might be important. Other things that could be important for us, maybe you'll get to, is maybe are there any risk factors for his epilepsy? So these are some things I'm just thinking about as you're presenting the case.
Okay, so one of the things is definitely is not common generalized tonic-clonic seizures, you know, in most of the focal epilepsies. Okay. The other thing that I would like, I went back to this particular slide because what was described as staring actually was episode of unresponsiveness, and what he was having mainly during the day was difficult to talk. You know, he was having, it was like a speech arrest more than really staring. Yeah. Okay. Sometimes he was able to interact during this event even without talking. Okay, but definitely there was also some decreased responsiveness. Yeah. Okay. In terms of localization, I think when we try to describe the staring versus the difficult to talk, I think it's something that we can discuss. We can discuss.
Well,
more.
It's a really important thing actually, because staring with decreased responsiveness and hand automatisms, we think of complex partial seizures. I think most neurologists would put that into that one lump category, but which highlights the idea of misconceptions that you might have coming in this sort of presentation, getting a very broad review of the seizure semiology without actually knowing what actually is happening to the patient. Because staring with unresponsiveness is completely different than a language dysfunction, is from what I'm hearing from you, that's what seems to be more important with him.
Yeah. I think that this is one of the key
Maybe it would highlight,
you know,
the importance of actual video EEG evaluation in this case, where you can actually look at the semiology in a case who's clearly medically intractable.
And actually, that was exactly what happened. You know, during the video EEG evaluation, we were able to clarify the semiology. We were able to identify. That definitely helped also for the localization and lateralization of the focal epilepsy that this particular patient had.
Excellent.
Okay. I don't know if
we can go
if
ahead.
I comment or I can go ahead and just those are the findings that also, you know, because thinking about language in right-hand dominant person, you know, the left hemisphere will be responsible for this particular function. So this video EEG also highlight that exactly that lateralization that we can prove interictally, you know, seeing those repetitive spikes, fast activity, polyspiky activity, that is definitely, you know, in the left hemisphere, in the left frontocentral region as we described.
We can't wait to get to the invasive, so let's move along.
Yes.
Okay.
Let's go. So, but at least it's certifying the same thing. And when we saw the seizures during the video EEG monitoring, you know, also this type of activity, you know, in the same electrodes that I showed before, you can see this fast activity with nice pattern in the anterior frontal and frontocentral region, and then with a nice evolution, and then by the sudden this abrupt, you know, generalization that evolved many electrodes, and finally, you know, probably some attenuation in the activity in the left hemisphere more than on the right hemisphere. Okay. So I'm probably here. Okay. So here is thinking about the etiology. The patient has a normal neurological examination, no epilepsy risk factors, okay? And the early MRI was read as normal, okay? So I think at this point, we're gonna have one of the first questions. So in children or young adults with no epilepsy risk factors and drug-resistant focal epilepsy, the most likely adult finding on otherwise normal brain MRI is focal cortical dysplasia. I think that's for the audience.
For the audience, huh?
Correct?
Dr. Gonzalez-Martinez, would you care to answer this question as to your best thoughts?
In my best thought, I would say this is true. You know, otherwise normal brain is focal cortical dysplasia, maybe the mild forms of cortical dysplasia, I would say yes, it's true.
Certainly. Thank you.
We could also comment about the EG, because just to say that the so-called intellectual abnormalities are not only spike or slow wave or rhythmical wave, but also fast, burst of fast activity as we saw here. And this burst of fast activity were in localization in the anterior frontal lobe, exactly from where the seizure started. And so this presence of fast activity on EG, localized and always repetitive, with a fast onset, is in favor of a focal cortical dysplasia. It doesn't mark it, certainly, but it is clearly in favor of this.
Very suggestive. Thank you, Dr. Chauvel.
Okay. So let's continue now.
So he was right.
He was right. You were correct. Yeah. Okay, and this is the MRI that was reported abnormal. This is a coronal flare CAT that probably Jorge can describe better than me.
So interestingly, this MRI was read as normal, correct? You know? But when you really analyze and you have the arrow sign over here, it becomes easy. But those are very subtle findings. You can see some those are flare, coronal flare images showing some hyperintensity in an area that we call the inferior frontal gyrus on the left side, left frontal, inferior frontal gyrus. Probably more anterior portion of the inferior frontal gyrus called pars orbitalis. As you can see, there is changes that goes all the way from the cortex and goes all the way to the white matter. And if you really squeeze your eyes into this gyrus, more the cortical areas, you can see there are some also changes in the cortical gray matter areas in that location that are, at least from an imaging point of view, very suggestive of malformation of the cortical development.
Okay. So just just as a comment, many times, during our patient management conference, we review all the MRIs, we review all the studies, and many times happen that MRI that was read as normal before, during the revision with the epileptologists, with the neuroimaging people, and thinking, about localization, we can delineate some lesion that probably can be missed, in the overview in the early review of the MRI.
And this situation is quite relatively common, what we call the almost normal MRI, an MRI that was read as normal. And when we review the data with more time and more in details, we see subtle changes like this one.
Okay. Is the MRI lesion the only important thing, Dr. Chauvel?
Yes, but not only. It's clear that the MRI lesion is important, but we have also to integrate this into the general frame of EG, intellectual and ictal, and also semiology, because if all the data from intellectual activity, electrical ictal activity, semiology, and imaging converge to the same area, I think we have found, and in many cases we don't need any intracranial investigations to operate. So why did we undertake this type of intracranial investigation if we did?
Okay, when we get more into the case, we can discuss that particular point, if the indication was correct, or we could do something different.
I think he's asking a good question, though, because this is often all we know at a certain point. We don't get a whole lot more information right now from what we have. And the first question that comes up to my mind is, how much of a margin needs to go, how much epileptogenic tissue is around what I see with the lesion, and how close is it to language? Because this is the left-sided, this is left hemisphere in the right hand. So I would immediately be thinking that the goals of my invasive evaluation and why I might need one is that I want to take as much as possible to be successful, but I want to make sure it's strategically removed so as not to impair any language function. And I might need invasives for that. I might need subdural electrodes to map out language and make sure that I have not harmed it.
And if I may compliment, when we review this MRI, this is you can see now a lesion, but you can also see this is a lesion that has very unclear margins. It's very different than a lesion that you have a very clear delimitation. This is something that is very blurry, and I can see the core of the lesion, but I really cannot see how extensive this lesion. And as you mentioned, this is in the most likely in the dominant hemisphere, left side. Probably primary speech areas will be close by. So those are the concerns that I have as a surgeon going after this lesion.
Okay. So we know we can do different things, you know, because try to answer Dr. Wyllie's questions, you know, when we try to delineate the lesion, when we try to delineate the function, you know, we can do extra-operative and we can do intraoperative studies or tests to delineate these, okay? This is an adult, so that's something that also can be done in the OR, and the patient, if the patient can cooperate with the evaluation during the OR, or it can be done in this way, which is extraoperative, you know, chronic implantation, where we can look for the function, reproduce the findings many times as possible, you know, just to give the surgeon all the information to resect exactly, you know, as much as possible without producing any deficit. I think there is another slide that show exactly the same findings, Jorge.
I think, you know, this is axial flare, and again, we see the hypersignal changes on the frontal lobe on the left side, more specifically on the anterior portion of the inferior frontal gyrus, or also known as pars orbitalis. But this picture shows very clear the tract that communicates this white matter changes all the way from the cortex to the ventricle, to the frontal horn of the lateral ventricle, which is another very typical sign of malformation of cortical development, a sign that we call as a transmental sign, that it communicates the gray matter all the way to the ventricular surface.
So in other words, a developmental abnormality, which we know has high epileptogenic potential, as opposed to simply a subtle gliosis, which may or may not have anything to do with the epilepsy.
That's correct.
That morphology really puts us into the likelihood of a causation. Would you agree, Dr.
I
Gonzalez?
completely agree.
Mm-hmm.
I have a question for you.
Yeah.
Would you recommend any particular regions of the brain that has to be carefully studied? Because I have the sensation that many times the cortical dysplasias are always in the same places. You know, in different patients, you find abnormalities on the same places. This is one of those. You know, very close to the functional area in this particular, you know, opercular region. So there is a region of the brain that we have to pay more attention, because it's difficult to see the abnormalities on the MRI because they can be hidden, or because there are regions of the brain where the cortical dysplasias are seen more commonly.
Yeah, this is a very good question, and I don't think we have a clear study ever where the malformations of cortical development are more common. We know that there is a tendency for them to happen in the frontal lobe, like this patient, but specifically in patients with what we call the almost normal MRIs, I would probably pay very much attention into the depths of the sulci. This is an area that more and more we see more the occurrence of malformations of cortical development at the depths of the sulci. So I will definitely in those patients that we call almost normal or normal MRIs, I will definitely pay more attention into those areas. Another areas, and again, it depends on the patient's semiology. If the patient has a semiology or a clinical semiology that is more related to motor seizures or sensory seizures, we will look more intensely into the depths of the central sulcus, pre-central sulcus, post-central sulcus.
Okay. So what other tests would you like to have now? Just everybody in the
Functional MRI for language, although I would suspect it would support our suspicion of language on the left. Mm-hmm. You could do a PET, but I don't know if it will add much. I don't think you need an ictal spect, but you could do it.
Okay. So
MEG you could do. You can do all of that, but the bottom line is you probably could
want
live.
to know.
If I could have one test, I'd probably do the fMRI and
okay.
plus minus everything else.
That's what we did. So, and that's what we have here. And as you can see, you know, the overlapping of the previous abnormalities with these language areas activated during the word generation task, the listening and the rhyming over the left hemisphere, and basically the word generation activating in the frontalopercular region. Okay, so that's enough information. Yeah.
Go to the next slides.
Okay.
I know that we want to get to the invasives with this.
Okay, this is another question. So when comparing subdural and stereotatic depth electrodes, which of the following is false? Subdural electrodes may afford more extensive mapping of eloquent cortex. Stereotatic depth electrodes may afford more precise recording from deeper regions away from the cortical surface. Or subdural electrodes have a lower risk of complication than stereotatic depth electrodes. Remember that we are answering here, just for the audience, which is false, okay? Okay.
Dr. Gonzalez-Martinez, you work with these every day.
Yeah.
Which is the wrong answer?
Trick question, but what we have so far, I think we can say that probably the wrong answer is the subdural electrodes have a lower risk of complications than stereotatic depth electrodes. In the past, we have the impression that putting depth electrodes in the brain because we're invading the pia and the cortex would be more morbid than putting just electrodes on the top of the cortical surface. When we did a meta-analysis, we see that in general, the rate of complications with subdurals are higher than the rate of complications with depth electrodes. I would like to also emphasize this has to do with the technique of implantation. With a good technique, probably the placement of stereotatic depth electrodes, also known as SEG, will give us less morbidity than the subdural implantation.
Okay. Any other comment?
The other two distractors on there is a little bit harder because we should just review them. The subdural electrodes may afford more extensive mapping of eloquent cortex that relates to the fact that subdurals are a contiguous electrode sheet array. And so in this situation where you have language, you want to have peel surface coverage. So you do not necessarily get depth electrode or depth of sulcus coverage, but that's not usually a problem with eloquent cortex mapping. The other is that other distractors, stereotactic depth electrodes may afford more precise recordings in deeper regions from cortical surface. And that's true because of the nature of the electrode. It's penetrating into the substance of the brain. Of course, it depends upon where you place these electrodes.
Correct.
And so if you want a specific area, you have to have accurate pre-implantation hypothesis to drive that question. And then also you need to get good stereotactic navigation to get to the area that you're hoping to see.
And I think you just pointed out a very important thought that we grapple with a lot in our management conferences. If we're going to think about invasives, it has to be a testable hypothesis, an actual question that we know we can answer with one or the other techniques.
Right.
And as you just pointed out, the question we're answering will tell us which technique or combination of techniques we should use. Do we want to know localization at the depth of something versus superficially? Or do we want to know a centimeter differentiation between language and epilepsy?
Right. So, it is particularly important to the way we're presenting today in the webinar. We're trying to get to the information in the invasive, but that's not at all to say that what happened before is not so important. As a matter of fact, that is the most important part of an invasive evaluation, is the non-invasive evaluation.
Exactly. And when our question for the invasives is, we don't know what's going on, please
Right.
help us,
Yeah.
that is the wrong question.
Exactly.
And we shouldn't be setting ourselves up that way.
That's correct.
Yeah, definitely no. Yeah, because you can get more in trouble usually.
So on the other hand, what I think I may rephrase what you say, the invasive, whatever is subdural or SEG or depth electrodes, is to confirm or reject a hypothesis, a pre-implantation hypothesis. If your hypothesis is wrong, no matter what technique you're going to use, the conclusions will be wrong. So the most important part of everything that we do is the hypothesis, and we use invasives to confirm it or to reject it, and not to create new hypotheses. This would be a very
very hard
tricky
lesson
situation.
that we've learned through the years, that we've always, and I think exactly what you said, Elaine, is that coming into this, when the way we've gotten better at it, at invasives in a way, correct me if I'm wrong, is really bringing people who've done it for a long time, telling us what's important in the semiology, what's important in the imaging, what's important in the AEG that we need to pay attention to answer the questions that we want to ask.
That's a beautiful way of putting it, Dr. Gonzalez-Martinez, in my opinion. Very cogently said. I might add one further thought, which is that that if we already know the end game, in other words, our hypothesis, there are things open to question, but there's only one action plan, and we're either going to take it or not take it, with or without confirmatory evidence. This is where some controversy comes in. Some people like to confirm things with invasives just to feel a little more comfortable. Some people are more confident with an examination from pre-surgical testing. But I'd like to throw out the idea that if there is a reasonable way to spare a patient from invasive electrodes, that should be our effort. If we think we know what to do without invasives, we should not use invasives. But if we have an hypothesis we have to test, that's when we bring it in. To great advantage, I think, in the way that you have done it for us.
No, but at the end of the day, the surgery will be invasive. So we
Yes.
need to be very, have the most proof as possible of the localization.
Okay, let me move here to the next slide. And
So you're right again.
okay,
That's 2 for 2.
you are very good. Okay, just let's see what we did here, and this is just samples, of the type of implantation that this patient had. And someone can say why we cover other regions that there is no lesion or there was not suspicious that the seizures were coming from there. Well, when you plan an invasive evaluation, you try to prove one hypothesis, and the most important part is also to try to rule out other hypotheses, And as we said here before, we covered the frontal lobe quite extensive because the lesion was not as extensive, but just to delineate the maximum possible resection in this particular patient. What you can see here on green is exactly where the lesion was, and this lesion was attacked by this, covered by the subdural grid and also by 2 depth electrodes, that give us also information of the deeper structures where the lesion was sitting. So just to move on this one, so we have here another question, say, which of the following is the most highly significant and characteristic electrographic finding of focal cortical dysplasia? I think that Dr. Chauvel already said something, but here are the options for the audience, which is continuous repetitive discharges, high amplitude spikes, high frequency oscillations, and 4 EEG seizures with no clinical signs. Okay? I think I will ask Dr. Chauvel if you want to comment about...
This is the data that comes from here is a lot from the intraoperative setting, not as much as from the extraoperative implantation that we have, but from the intraoperative evaluation of this particular pathology.
Okay.
I think everything is true, but I don't understand what are EEG seizures with no clinical sign. You mean that fast activities, which are exactly the same topography and the same frequency of the seizures, but you don't record any?
So the question is asking if I can, is specific, what of those is specific to focal cortical dysplasia? So if you saw, and that's why I said much of the data that supports this answer comes from the intraoperative setting, is that from the intraoperative setting, they've looked at cortical dysplasia.
You can find this. Depends on the dysplasia, depends on where is your electrodes. But all these have been described in focal cortical dysplasia.
Okay.
So this is a question of controversy.
Yeah.
But the answer suggested by the person who wrote the question is, next slide will show us.
Yes. So this is Dr. Palmini, Andre Palmini's. This is one of the findings that he came across with his intraoperative monitoring of several cases of focal cortical dysplasia, and was found actually, I think, pretty convincingly that if you leave behind areas that show continuous repetitive discharges, they're more likely to fail. And intraoperative monitoring has a limitation, and the limitation is time. You can't really monitor for long periods of time, so you're really limited to the interictal data. That's why I was trying to help steer the navigation of this answer, so maybe it wasn't a great question. But he found that most of those pathologies were cortical dysplasia pathologies. That's what it tended to show, focal cortical dysplasia.
I think there is also evidence from the French group. Some French group described this one, that the continuous repetitive discharge
yes,
can be seen.
I agree, but it is only one of the aspects.
Yeah.
So maybe it's one of the more common ones. Yes.
Yes, when you have this totally, I mean, by repetitive discharge, it means probably it's small amplitude spikes permanently, with periodic, that's okay. Yeah. But we have not to discard, to eliminate the diagnosis of FCD if you have the other types.
Right, that's right.
Yes.
I think what they're saying is, like for instance, the high frequency oscillations, the high amplitude spikes could be seen in almost any sort of pathology.
No, because high frequency oscillations, you can see also
within normal cortex.
With spikes.
Yes, or within normal cortex itself, normal functional cortices.
Are not the same.
They're not exactly. The frequencies may be different,
Yes.
Can I ask a question as a surgeon who doesn't understand much about EEG? We are talking about interictal electrocorticography features.
That's right. Yes.
So interictal, not ictal. Okay.
Not necessarily ictal, you see.
Yeah,
But
interictal.
Yes. Obviously, seizures would be indicative of a focus, but it may not be indicative of the type of nature of that pathology. Is what
Fortunately, we have other ways to make the diagnosis. So.
Exactly, like microscopic evaluation of the tissue.
Let me show you exactly what we try to highlight. Now, that's one of the page of the invasive evaluation that you can see those repetitive spikes that are marked with the. It's difficult to see from here, but you can see the red arrows in all of them, and then they were very much, around, the lesion that was delineated, and this is one of the seizures that the patient had with clinical signs, that you see the onset in almost in the same electrodes that we have seen those repetitive spikes interictally, and this evolution of this discharge, to another electrodes later on. And you can see in the schema on top of that what is the spread pattern that we have seen, with the red, really solid red, electrodes started, and then the other spread on the pink.
Juan, can you go back one slide? I just want to highlight one thing that I think may not be as clear.
Okay.
You might even argue, and we had a debate, I think, on this, is that you might even argue that the ictal changes were occurring before. You see this very high amplitude spike that occurs. That's what determined the onset, I think, for most of us. But you could argue even in this region that there was a change in the interictal nature of things. You went from a continuous spike discharge into a suppression of EEG and then this fast. So that kind of highlights this idea that there is, even though we divide things between interictal and ictal, that there's very likely a spectrum or a change that occurs that's a little bit not like a switch, but rather kind of a gradual evolution. The other thing that I would highlight in this is the relative restricted nature of the propagation that we see.
Yes.
That's a very good sign, I think.
The point I would like to do, because this is a very illustrative case of a very focal origin. But with the same etiology, with the same type of image, you could have a much more extended spike and fast discharge at the onset.
Yes.
And that means that you cannot have a priori about the extent of the what we call epileptogenic zone.
Yeah.
That means the electrophysiological organization at seizure onset and the lesion. Here we have, but it's why the intracranial investigations can be very useful in what we can map what is really lesional and what is really epileptogenic.
Yes.
Most of the time in FCDs, it's fully overlap.
Or it's on the border, as
But-
Elaine was coming to, is that
And
it's at
also on the border, yes, it's
yes.
not exactly the same topography. So it's important to know. But you see it, you have not this repetitive spike there.
There's a change.
Spike,
It's a-
change,
yes.
amplification that means more synchrony than faster activity.
I see some activities coming from the depths of the electrodes, and what that means from a. In
From
terms
us,
of
actually, it's coming from the depths, but it's the more superficial contact of the depths.
Yes.
Okay, if you look at, in the box, So the lower part of the box is the more superficial contacts. So it's very close to the grid, actually.
Peel cortex.
The peel cortex, yeah, exactly. So the more deeper ones show nothing. They are really more flat, you know, yeah.
Yeah.
So
And this activity in the depths is close from the two
it's
red
close. If you
spots.
see, there is a black dot
Over there?
next to the red dot. So
Okay.
it's just over there.
I see.
So that's the same. So it's the same region, you know, activated and synchronizing.
So pretty much the subdural grids and the depths are seen the same.
Okay.
And this brings up an interesting point. You elected to put in a depth electrode as well as the subdural. So you were bringing together both questions. Mostly you were focusing on the localization of eloquent cortex, but you also wanted to sort out a little bit the relationship between the deeper lesion and the spread patterns and the epileptogenicity on the outer surface. Is that a fair characterization? Anything that...
It is, and one thing is if we think that the cortical dysplasia, the depth of the sulcus is where most of the time we have the bulk of the abnormality is important, and the other thing is also give information for the surgical strategy. So in terms of the how deep the surgeon can go, I think it's information that can make the surgeon feel more comfortable and use that information in the surgical strategy.
So it adds a 3D element.
That's the idea. Yeah. Okay. Let me continue here. Another slide, just the continuation of the seizure, and this is basically very similar, but just this highlights something that is often to see on invasive. That many times the patient do not have a clinical manifestation. But we can see EEG changes, you know, definitely. And most of the time, they are consistent with the same place where the seizure started. Some other times, you know, they are not in the same place, those MCSs, that is the way we call, no clinical signs. But I don't see the
Middle, probably.
that one? I don't see the...
But it's 1 to 2 per hour, which is shocking, really.
Yeah.
And we're seeing
Yeah, it
this.
is.
We're
Okay.
seeing this more and more in the.
So is this activity that we were talking about this primary this first organization here, and then the change, you know, in the type of activity, and then the evolution that.
As you see it in
we
the
have.
depth electrode, like you mentioned too, Jorge.
And it's also on the depth electrodes, and it's also
on the peel surface.
in the surface.
This is a very important point but you can use it as a marker of the epileptogenic zone once you have recorded fully clinical seizures. And after you have understood that the full clinical seizures will probably have the same onset and with spread will produce semiology, you can come back to the more subtle organizations of the condition that have the same topography. And personally, I would rely more on this for surgery than on the full extended seizures. And that is the same in SEG. The subclinical electrical discharge are very important.
Luckily, the electroclinical the electrographic markers are identical.
Yes.
So the very initial changes are identical.
Here it's relatively easy because it's
restricted.
again it's restricted, it's limited.
Yes,
Sometimes,
but your point is
when
well
you have
taken,
a faster activity at the onset, you don't see really where it is, and you rely more on the predictal spike and the building up of this predictal spike. They are a better marker than the extent of the fast discharge.
Very good.
Let's continue.
Wonderful.
Just to have time for the next case too. So here is another question. Which of the following conditions should be met for speech arrest during cortical stimulation to reliably indicate that the electrodes overlies language eloquent cortex? No effect on tongue mobility, no significant EEG after discharge, non-eloquent reference electrodes, all the above. That's for you.
Yeah, I know this is actually a question just to highlight the complexity of trying to understand cortical stimulation. Because you might get some false positives if you say that this is clearly a language area, but you did not test to make sure that there was no tongue motor involvement, or that you may not have understood that the patient had a seizure during that moment in time. So there are these very important negatives, right? So what's the answer here? Do we know?
All the above?
All the above, is that what you say?
Yeah.
Let's see what you said. All right.
Oops.
You're right.
Go back.
You're right again.
Okay.
Very good.
I think that this is important from the cortical stimulation, because if we call everything that the patient that produces speech arrest on the patient, and we don't define all these points very clearly, we're going to give the surgeon 16 electrodes, with the language area. Finally, we cannot do surgery. And
we'd fail in what the original intent of this
Yeah,
was.
so that's one of the points that is important, during the cortical stimulation, to be sure that these elements, are verified, that to have a very localized.
So question, is this for motor speech, Broca, or any speech areas?
Any speech areas.
Any
Because
speech. So
in
no
fact,
effect on tongue mobility, this also...
It's interesting what happens with cortical stimulation, in fact. We don't test necessarily that point on it, but you want to make sure, because you would expect, you might have an expectation that what you're doing with stimulation is you're taking that node out of the network.
Correct.
However, that's one possibility, definitely. The other possibility is you're activating the network in its entirety. And so we have seen what actually happens, very interestingly enough, on the Wernicke side of things. This wasn't a Wernicke case, but if we were trying to test for Wernicke language, what we get is a Broca aphasia,
Okay.
speech arrest,
Yes.
which is often not expected in a stroke, but it's because of the nature of the way we stimulate. So we do those types of tests even there in the Wernicke, because we want to make sure that this isn't a seizure or this isn't some sort of other kind of spread phenomenon that we can't explain. So isn't that right, Patrick? But we do testing in terms of how are we testing language more sophisticatedly. Is this a posterior language function or is this an anterior language function?
Yes, but what you expect and what you get is speech arrest.
Exactly.
But also because you inactivate with subdural grid, you inactivate a bigger region. And that's why the process is totally different from ECG. From ECG, it's very rare to obtain speech arrest stimulating between two leads of the depth electrodes because the network is bigger.
Yeah.
The process is totally different.
And the electrodes are smaller,
yes,
to be fair.
But so in ECG, you rely on correlations of language impairment during seizures.
That's right.
So the process is at one at the same time, recording seizures with correlations and making functional mapping. Here, you compare the two areas, and if they overlap, you know that you cannot operate.
Yes.
So that's not the same process.
I think both of you brought to the discussion one thing, which is network and what is region. And
yes,
you mentioned this one, which is very important because the activation that we have is probably a network activation.
Yes.
Okay, it's not just a 3 millimeter spot in the brain, but you have those entry points, and I think those are things that
topography in the two methods are not the same meaning.
Are not the same. So that's why the interpretation should be different. Okay.
Dr. Gonzalez-Martinez, Dr. Juan Bulacio, we have a question from our colleague, Dr. Mar Carreño, and she would like to know that in those areas of transmental cortical dysplasia in which no invasive studies are done, and of course we don't always do them, so she's quite correct to highlight that, what is the need to remove the tract that goes from the cortex to the ventricular surface?
It's a very good question from Mar. It's something
who's
that
a colleague trained here.
Who's
so
our
it's
colleague.
a very good friend too. Yeah.
So this is a question that was answered with the depth electrodes and also with seizure outcome after resections. It's clear for us that there is no need to remove the flare changes or the transmental sign that we see that are next to the ventricle. And in fact, those changes should not be removed because that's where the association fibers not related to the epileptogenic zone are going through. So there'll be a good chance that you're going to remove the transmental sign. You're not going to have any benefit in terms of seizure freedom, and then you're going to have a deficit because you are disconnecting fibers that are not associated with the epileptogenic zone. So I think the take-home message is what I do in my practice. I will remove the white matter changes that are associated within the sulcus that we need to resect, but I limit my resection to the bottom of the adjacent sulcus. So in that way, I don't go deep into the white matter after those everything that we see on the MRI. So just the white matter changes that are associated with the cortex and of course the gray matter associated with it.
Thank you very much, Dr. Carreño. Dr. Bulacio, shall we move on?
Okay, we move on. Next, just to show a combination of the ictal and cortical stimulation findings. As you can see here, that was where we mapped the ictal onset, the early spread in this particular patient, and the areas where we were able to produce speech arrest. And
it's very close, the speech arrest. Isn't it interesting how it's just one electrode away, at least from that one of the two?
Yeah, one of the two.
So within 3 centimeters maybe, yeah?
Yeah, less than millimeter, yeah. And then here is just the OR picture, the previous OR picture that we have shown, that where we can identify the language areas, the ictal onset, and what the surgeon can do. And here, I pass to you, Dr. Wyllie. So this is the neurosurgical that we're gonna ask Jorge the questions about the resection that we have.
So based on the subdural grade recordings, and we kind of define what areas where what we consider to be the epileptogenic zone, which include the lesion, which luckily for this patient was outside the speech areas. And we were able to resect the lesion and the adjacent cortex, the context that shows the ictal onset, and also what we define to be the epileptogenic zone. What I would like to make a point here is that in general there is a common sense or a common dogmatic mention in neurosurgery that once you find eloquent cortex, you should stay at least 1 centimeter away. You should give yourself 1 centimeter margins to really prevent a deficit. That's not necessarily true, specifically in this area. Because in this area we have a very clear landmarks that tells me that this is Broca area and this is outside Broca area. And those landmarks are south side, the ramus of the Sylvian fissure that really defines me what are the Broca, where is the eloquent areas and what are the epileptogenic zone areas. So the surgeon was able to really get into the very next limit of Broca without causing any neurological deficit. So this is an important point, at least for me. We can really go up to the limit as long as we have a clear anatomical boundary that allows us to go there without damaging the tissue.
Is there one more slide, I
I
think?
think there is one more, which is just the outcome, no seizures.
Yeah. So it's actually, I saw this patient in my clinic, and he's doing still fine. So it's a very good outcome. One other thing I wanted to say, this was a patient that I saw when I was at Fairview, and this is one of our regional hospitals in the epilepsy monitoring unit there. The reason why I bring that up is that these cases exist everywhere, not just in the tertiary care epilepsy centers. So when you have a patient, I would say, that has a quote-unquote normal MRI scan, I don't think that should be the limit to say this is not a good surgical case. Because it involves, I think, a little bit more sophistication than that to kind of pick up on all these details that were brought out here to come to this unique outcome, I think. Not unique. I think in many epilepsy centers you have this sort of sophistication. But for those people who have these patients who are medically intractable and have a normal MRI scan, that's not maybe where you need to stop. That's all I would want to highlight.
This family was very fortunate to meet you in the community hospital after years and years.
To meet us.
But you were the touch point that brought it to the team.
Well,
and
each one of us has these stories. Thank you. You're too kind, Elaine. But
you have another slide, Dr. Bulacio. Please. Yes, you do.
slide.
Case highlights.
Okay. So focal cortical dysplasia is an important cause of drug-resistant surgically remediable epilepsy, which may be subtle or invisible on MRI. Subdural electrodes close spatial resolution of the epileptogenic zone in relation to the eloquent cortex. Stereotactic depth electrodes recording from deeper regions. And the choice of either of both techniques must be individualized in every case. I think that's the last one.
Thank you.
Thank you.
And we have another case. Dr. Nair, were you?
This is the case that I think Dr. Gonzalez-Martinez and
Who's
Professor
going to
Chauvel
present?
has put together.
I can present, I
Okay,
believe.
pass the, there we go.
All right.
Okay.
So
Thank
how
you, Dr. Gonzalez-Martinez.
how it goes here, let me see. So,
That one.
Yeah.
So I have no disclosures, neither my presenters. Very good. So this is a patient, it's a pediatric patient. We name it COD. So onset
Cody.
of seizures, Cody.
Sorry.
Code.
I named him, so I apologize for that.
Cody. So onset of seizures at 9 years, of age. Patient had a nora, feeling of emptiness in the head, followed by staring, deep breathing, tonic stiffening of facial muscles, followed by senseless, wandering movements that the parents describe like a robot. This is pretty much the description of the semiology for Cody. He comes to us with 17 years old. Now he has 20 seizures per day, so quite severe epilepsy, mostly in sleep. He tried 8 antiepileptic medications, vagal nerve stimulations, and medical marijuana. So as you can see, this is a severe, very medically refractory epilepsy. And he is struggling in school. This is the scalp EEG. I will not comment those waves. I will ask one of my colleagues, maybe Dr. Nair, if he can make us.
So yes, putting this together, it's actually interesting how some of these cases share similarities. Again, a high seizure frequency, mostly at night. This is telling me that this is something that's atypical from a temporal lobe, mesial temporal lobe epilepsy. We wouldn't expect that presentation. The other things that are interesting about it, which I'll let Dr. Chauvel speak on, is the other aspects of the semiology. This particular this EEG interictal page we're seeing here is a spike and wave discharge. It's relatively regional in our scalp EEG. It seems to be maximum at F3. And if you look at the montage laterally, on the more lateral temporal montage, FP1 and F7 are almost equipotential. So the next likely fall off there is more frontopolar. So it's midline frontopolar on the left is where we're seeing this interictal discharges, which is interesting and important aspect of EEG to focus on, because often our interictal EEG gives us more precise information about localization as opposed to sometimes when we see our ictal EEG, I would say.
Sometimes you can have a quasi-normal EEG in this type of epilepsies. And so what's important also is not only, obviously, semiology we could discuss about, but it's when you don't get sharp spikes like this, as the patients are presenting clusters, seizures in clusters, the postictal aspect is very important.
Absolutely.
And you can have a relatively focal or focal regional postical slowing, which is very localized.
Yes.
And because the semiology can be very difficult to identify.
And even this EEG, I think if you look at it closely, interictally, there's probably slowing. That's what you're picking up in the frontopolar regions on the left, as compared to the right parasagittal chains. You can see an asymmetry decreased in the background rhythms there. That's a very good point.
Any other comments? No? Think we can go forward. Very good. We also have frontal polyspikes.
And fast activity.
So what that means?
It could be one of the markers, of epileptogenic region.
A more restricted area, or not necessarily?
Not necessarily, but definitely, it's pointing here. You have lateralization, which is very good, and you have a nice localization. It's quite anterior, and this, and we cannot put all the money, just in the paroxysmal fast, but it's one of the pieces that we have to put into account to consider, where is the epileptogenic region.
I think the other thing that we could look at this here is that look at what's happening at the FZ chain, midline chain. There's relatively little involvement of FZ. So then if we think about this, how this would appear on a map of this potential, it's F3 and then moving more to the pole on the left, not moving posteriorly midline to the FZ. So this is actually helping us, not only in regionalizing it to the left paracentral, but something rostral as opposed to caudal in the frontocentral region.
Paramedian.
Paramedian. Exactly.
Correct.
Because yes, you are right. I think the activity, the frequency is faster on the midline.
Yes.
It's like in the previous case we have this type of
Very similar. Some things are similar.
Let's go forward. This is his MRI, and it was interpreted as normal. We look at this MRI during the preparation for this patient, and definitely our neuroradiologists and our group teams didn't find a specific lesion. And specifically, we look at, because of the signs with the scalp EEG, we specifically look at the left frontal areas to see if there was any specific areas over there, but we didn't find anything remarkable.
So truly normal, not pseudonormal.
This is what we found that was, in our eyes,
Yes.
this was
and so this is sometimes
normal
a
MRI.
frustrating aspect of epilepsy when we come to the most sophisticated imaging that we have, and that doesn't give us what we want, which is some sort of sign where to go.
Very good. I will
But our
proceed.
EEG's helping.
Yeah. And the PET MRI, the PET scan for this patient was also considered normal. But when we analyzed a little bit close, and again, you can see that there is probably a hypometabolism on the left side,
Would you like to
superior
have
frontal.
the mouse? You can show us that.
Oh, great.
On
This is great.
in the center.
Very
you
good.
go. Yeah.
So over here, there is an area over there that really caught my attention and my colleagues' attention as a possible hypometabolism on the PET scan on the left frontal, again in a more anterior position, more cranial, polar, mesial, which kind of was in very concordant with the scalp EEG, at least what we had so far.
Seems we should put a question mark after normal.
It was definitely a question mark for us after we reviewed, but this was reported as normal.
But it highlights the importance of all of the other data. We don't ever isolate, look at our imaging studies by itself. We always use it in comparison to other things. Sometimes it can lead us astray because we can pick up things that may not really be there.
But it sometimes
But
can
it's
give us a biased view of what we see, and sometimes
Absolutely.
give us the wrong direction. So
We have to be careful.
Yeah, very careful. Yep,
Yeah.
I agree with you.
You have to use good bias.
Good bias. That's right. So just proceeding here, we have here, and we have an ictospect, and I quite don't remember what is the time of injection here. I think it was a good injection, a short, early injection. And you can see here there is a very clear hyperflow here on the left side, anterior, almost in the frontal polar areas, and a little bit towards the mesial aspect. Kind of concordant with the results that we previously discussed about the scalp EEG, and also kind of concordant with the results of the PET.
So
I don't know
Jorge,
if anybody wants to make any
Just to
comments.
clarify, those in the audience who may not understand what you mean by the time, ictal-spect is very highly dependent upon when the injection was given in relation to the EEG onset or clinical onset. So if you're delayed in your injection, you might see areas of hyperperfusion that might reflect distant regions of propagation. I wouldn't say propagation, because propagation is always what we're looking at with ictal-spect, but maybe late injections might not give you the idea of where some early regions of the brain could be activated. Is that what you mean by
That's
that,
correct.
right?
Yes, thank you.
Yeah.
So anatomically speaking, I think we're talking about PET scan and ictospect to be concordant in the same anatomical region.
And EEG.
on the left
too,
side, and
right?
the EEG,
Yeah.
and the EEG too. So let's proceed here.
In both patients, the video EEG was very important too.
I would agree.
For the semiology.
Here are the results of the MAG scan that we perform. We have the luxury to have a MAG scan in our hospital, and this was particularly a very interesting result when we can see again a cluster of dipole activity, MAG activity, that is centered again on the left side, left hemisphere, mesial frontal polar areas. Again, a result that's very, very concordant with the results of the non-invasive data that we have so far. I wonder if I can have maybe Dr. Chauvel would like to comment about the results of this MAG.
It's easy. You see a cluster of dipoles that mean that all the source localization of different spike recorded were in the same place. That is really quite reliable. And so you can see also 1 or 2 dipoles on the contralateral side, which we can expect because you have spread, transcallosal spread of your intellectual activities. So this is a good marker.
And I'm noticing that in comparison to the other case, we're using all our tools here.
Yes.
Because in our other case, we decided to just opt out of not getting ictal spect or MEG or PET. And in this situation, we're dealing with a different problem.
The whole difference is non-lesional MRI.
Yeah.
Very good.
We love our MRI and it trumps most other things, but when it's negative, we have to work hard.
That's right.
So I think here is the information that we have from a non-invasive aspect. So as a surgeon, I would ask question, can I go ahead and operate him right away based on the information, or we need something else? We need an invasive phase. Is invasive indicated, or we can just go there and remove the frontal polar areas or not?
Right. It's a question, and I know you're asking that to kind of spark debate, because most people, I think, would, in the most institutions, would not do that based on normal MRI scans. But it's an important question to ask. When you have, because there are limitations of each of our non-invasive studies that we look at, right? So we talked about how ictal spect has a limitation because it is looking at propagation from ictal onset to various regions. MEG has a limitation as well because it is looking at interictal periods, and if it is good when we have nice tight clusters. But if MEG is looking at interictal and doesn't see ictal, or it doesn't see that continuum from interictal to preictal to ictal, it may not always give precise localization. PET scan, we've talked about. We looked at one image of hypometabolism that's a question mark. But there are many areas that in a PET scan can show hypometabolism that we would worry about and wonder about. So in that, with the limitations that we have in that we don't have a lesion on MRI scan, we're hopeful with all of what you're showing us that we've kind of being able to build a hypothesis. But I don't know if we're confident enough to send this patient right to you at this moment in time.
Although the opinion, I don't remember this exact case in patient management, but I would submit that this could likely be a divided opinion.
That's possible.
And that there are some of us who would say the SPECT looks exactly like the PET. The PET and SPECT look exactly like the MEG. The semiology and the scalp EEG are convergent. You could do this with, you have a posterior margin, which is you do not want to get in your language areas. So you already know how far back you can go. You have a very nice, probably non-eloquent zone there that is highly implicated. I think you could make a case for not doing invasives.
I think, Dr.
No,
Chauvel,
just
yeah.
a word. No, it's true that we are in presence of a constellation of subtleties, but converging to the same region. And so, for example, one of the question is, yes, you could operate, but which would be your boundaries? And if we will not analyze in detail the semiology here, but I remember that we had a sequence of signs, meaning that it was probably paramedian anterior, but with signs like this sign and the screaming at the end of the seizures, meaning that probably the spread could be very fast, very early to the cingulate region. So you need, do you remove only the frontal pole plus or less cingulate gyrus, pre-SMA, which part of? So there's a lot of questions, and as obviously your lesion is small, obviously your epileptogenic zone is small, it would be too bad to make a big resection. Is probably a small pathology. That's right.
So I think this is important point for me as a surgeon, that I can eventually have the discussion about performing this resection without invasive. But because this is a non-lesion MRI, I'll be most likely forced to do a big resection for this patient, because again, it's a non-lesion MRI. I don't know what are the limitations of this epileptogenic zone. And we're talking about the dominant
Which is a study with the more validation for us
Correct.
in terms of outcome, correct?
Correct.
So because I always say the same thing, you know, at the end of the ECG evaluation and when we present in the case, it's, oh, why we didn't do this without the ECG, but we have to keep in mind that the more valid study is the MRI, which is non-lesion and in this particular patient. So it's something that I agree with everybody in the terms, everything fit, but the MRI is still normal.
There's no wrong answer probably in this year. We
Yes,
probably
yeah.
can't say that it's wrong to do invasives or that it's right to do invasives, but it is an informed consent discussion about the pros and cons of each and guided by our own comfort level. So it probably either way could be reasonable.
And if we had a lesion like the lesion that we had in the case before, subtle lesion but with a clear malformation of cortical development signs, would you be a little more
Free.
towards non-invasive, towards a direct resection of this lesion plus
Yeah.
the tissue adjacent to it?
So I think it very much depends upon the center you're at, you know,
Sure.
and also the country you live in. Because, for instance, you may not have the resources to do a lot of these cases. And do you want to withhold surgery because you can't put electrodes in? So that's a very good point. And I think what Dr. Wyllie is also mentioning is that this is considered a relatively non-eloquent area if you did the resection that you were talking about, because you wouldn't be going into motor, you wouldn't be going into language. However, you didn't get to finish your sentence because I wanted to hear that. This is the non-dominant frontal lobe. And in any person, we want to, I'm sorry, dominant. I meant dominant. This is the dominant frontal lobe. And in any person, if you can do a smaller resection and still get the same result, which this is also comes back to your point in 2016, because we don't know. What are the cognitive impairments if you do smaller versus larger resections in young individuals over years? Or do we? I don't know. I may not be versed in that literature very well.
Very good. Let's proceed here. See what we have. So we have a first question. Indications for implantation of invasive electrodes for epilepsy surgery planning include, number one, localization of the epileptogenic zone in the absence of focal lesion on MRI. Number two, mapping of eloquent cortex near the focus of seizure onset. Number three, clarification of primary epileptogenicity in the settings of multiple lesions. And number four, all of the above. I'd like, maybe Juan would like to answer that.
All of them are indications, you know, for implantation of invasive electrodes.
That's exactly what was the answer. Number two question, which statement is incorrect? So a reverse question. One, subdural electrodes offer dense cortical, I think we did.
Yeah, we
did.
Subdural electrodes offer dense cortical coverage of detailed mapping of eloquent cortex. Two, stereotactic electrodes offer recordings from deep regions including sulci and mesial cortex. And number three, compared to subdural electrodes, entail a higher risk of complications. I think we clearly answered.
Repetition's always good.
Always good. Very good.
To reinforce the point.
Because of the discussion that we had, we here in our hospital, we selected to do an invasive evaluation for this patient. So which invasive evaluation would you do for this patient? I don't know. Dileep, you want to?
I think this question is very clear for me because you're asking your areas of interest require coverage that are relatively deep and hard to get to at the peel surface. So I would favor implanting this patient with SEEG because we have nice trajectories through the lateral mesial cortices that we can get to the cingulate regions, as you mentioned, the prefrontal, the frontal pole, the pre-SMA areas, that we can nicely map the extent of resections potentially.
And cingulate gyrus.
And cingulate gyrus, yeah.
Very good. Let's proceed. And this is exactly what we performed for this patient. We performed this implantation on the left side. This is a stereo EEG. This is a post-op X-ray, AP, and lateral view showing the placement of the depth electrodes. I think we implant 1, 2, 3, 6 electrodes. Small is a very restricted implantation for this patient. And here is the the location of our electrodes. Again, we selected to. I think this slide is a little bit. There is some formatting issues, but I will represent. Sorry. Can I go back? Very good. Sorry. So what we have here is, what is the? Very good. Got it. Okay, I think there is a shift in the representation. Here, the blue dots represents the entry point of the electrodes on the lateral surface. And here you have the O, which is more the orthofrontal over here. We have an electrode over here, which is the anterior cingulate, and electrodes that are in the frontal polar areas, one electrode exactly into the changes that we saw on the non-invasive.
On the PET.
On the PET. What we did here was a multimodal reformatting of the information. We fused the data from the ictospect, MAG, PET scan, and we fuse into a common space, and then we plan our implantation exactly in the area. So the L prime electrode is going through the confluence of the MAG, PET, and ictospect. And here are the results of the SEG and the anatomical location of the electrodes. And like to Dr. Chauvel, maybe comments, this is an interictal recording from...
Repetitive spike. Continuous repetitive spike. No, yes, it's very suggestive of dysplastic cortex there. What is important is to know if it is restricted, limited in one electrode, or part of one electrode, or more extended. In this case, it's really very local.
Just a single electrode, L1, L2, L4, L5. It's a very restricted area.
So we are not surprised not to see anything in MRI. That means that the size of the dysplastic cortex is simply small.
Yeah. Let me go next slide here.
Probably the other thing that we can highlight in this particular one is that the possibility to explore the sulcus here, because your electrodes are sitting in the sulcus. You know, is something that we have to keep in mind, that that's one of the possibilities that SEG give us, you know, that we didn't have with the subdural electrodes. Because someone can say, okay, why just we don't put an interhemispheric grid there, and that's we're going to have a good cover too. But I think that this particular location highlight that is in the middle of the sulcus, you know, which is not accessible for the grids at all. You know, that's one of the advantage that we can see.
And the interhemispheric grids can have a tendency to move. They have, if you know how these electrodes are placed, sometimes they don't get all the way down to cingulate regions, and they end up having the ability to kind of just sort of be not really tied down to the surface of the cortex.
I just would like to highlight here the one of important discussion about the differentiation between placement of depth electrodes and stereo EEG. And I think this is one of the features that we can highlight from SEG. SEG is a stereotactic placement of depth electrodes that give us recordings from deep cortical areas, but also precision. So I believe that the reason why we got such a focal area is because we were able to fuse all the known invasive modalities plus semiology and be able to place an electrode that was precisely in the area that we saw, which will not most likely happen if you do what we call depth electrodes, when you free implant electrodes the same way we did in the previous case. So it's an important differentiation, what we call depth electrodes and what we call an SEG. And I think the SEGs, particularly for this case, give us the precision that we had to really confine this area in one electrode.
Dr. Gonzalez, I'm sorry. Looking, now that we know just how discrete that area is, how really small it is, and as you point out, why it's MRI invisible, would the laser have any role here?
I think it's a very controversial question. and we don't have a straight answer for it. Laser is it's an FDA-approved methodology. It's designed for ablating small epileptogenic zones, and in the United States, it's normally used for mesial temporal sclerosis. So it's being applied in patients with lesional MRIs. So the use of laser in non-lesional cases, it's quite controversial. However, based on the SEG data, we turn a patient that was non-lesional in almost a lesional patient because we have a very, very focal area, very restricted. So my answer is yes, I think this would be a very good candidate for laser ablation. It will be also a good candidate for a resection, a conventional resection. I think we can go both ways. But the advantage of the laser here is that allows us to perform this operation with a in a minimal invasive fashion without the need for a craniotomy and with a very short length of stay. If we do a laser in this patient, he will probably stay in the hospital 24 hours instead of 3 or 4 days after a craniotomy. So specifically for patients where we have a very, very small restricted area, I think laser is a good option. Have in mind that our outcomes with lasers are very, very short compared to the outcomes of the standard resection.
So even though we're waiting for longer-term results, this to me takes us back to our earlier question about should we use invasive study for this case. If you have laser capability and if you think there's any chance this case might be a laser case, then you would, of course, want the SEEG data.
Yes.
So that would have driven you forward. If, on the other hand, you were in a hospital or a country or a place where that was not an option and you were going to do an open resection anyway, it wouldn't come into play. But at this center, for example, and many of the centers where our colleagues are now working, that would be an added reason to be more precise with our localization.
Absolutely.
Yes, and about localization, just if you look at this fast activity you show here, and it's a good marker. No, yes, but just to look at you see the spikes are in relatively local areas, and now with the fast, it's more extended. Mm-hmm. That's why when you record this, and we will probably show the seizures.
Let me see if I have seizures next.
Yes.
Let me see. Here we go.
Yes.
Correct.
And you see, if you have the onset of the seizures, you have spikes, then fast activity. If you compare with this and with that, you see that when you have understood the organization of these seizures, you know that the best marker will probably be the intellectual activity.
That's correct.
And so we are very precise, and we know exactly the very focal organization.
So just going forward here,
Yes.
This is the seizure that we record. Again, the seizure onset was in the L prime electrodes in the most mesial context, and with a very fast spread towards the more lateral context of also from the same electrodes L prime. And with a late spread towards the X prime electrode, which is the anterior cingulate that you mentioned before. Mm-hmm. So this is what the resume of our findings. We believe that our localization is really centered in the L prime electrode, in the most mesial context. And question number 3, potential indications for laser ablations of an epileptogenic lesion include mesial temporal sclerosis in the language dominant hemisphere, hypothalamic hamartomas, epileptogenic periventricular nodules, small, deeply located epileptogenic zones in a patient with a high perioperative risk. And I will ask this question to Dr. Wyllie, if you would like to answer that.
I'm voting 5, all of the above.
Yeah, that is.
And I think this brings out an interesting point, too, about laser, is that even if they're equivalent in outcome, if we eventually show that, there are some patients who really it's very risky to go through the intraoperative procedure.
Correct.
And this allows you to operate on a wider variety, it broadens your candidate pool. It lets you take care of people who otherwise might be too dangerous to proceed.
If I may complement this question, what we have in common here is very important, small areas, very localized, in general lesions, with a very clear demarcation of the epileptogenic zone. This is what the common denominator here in all those questions is small lesions in well-localized areas.
And this is an evolving area here. I think you mentioned that at the very beginning, that we are still learning a lot about when to do lasers, what are the long-term outcomes, what are the potential side effects, all of these things. Many institutions are going about this, as I understand, using some sort of IRB approach in some situations to kind of get all of this information. So I think that what we're talking about here is cutting edge, maybe not standard of care per se. I don't know if you would agree with that statement.
I agree with that.
Okay.
I agree with that.
What do you think about the first indication that is there, the mesial temporal sclerosis? Because it's one of the indications where surgery definitely has proven, very good outcome in the long term.
That's a very controversial topic. Mesial temporal sclerosis in language dominant. If we see the early, again, we are reporting early outcome results. And I'm not expecting that laser ablation will give us the same results. It will never give us the same results as standard on a standard operation.
Meaning more frequent seizure recurrence later, slightly lower rate of complete seizure freedom.
Most likely. But it's an option that will probably give us not the 70% seizure freedom that we see in MTS, but maybe 30%, 35%. So if you have patients that we have high medical comorbidity, or patients that are very scared about performing a craniotomy, this can give us access to, this technology can give access to those patients for the treatment. Again, this is very controversial. I think what's important here to be clear is that we don't believe the outcomes with laser would be the same as standard operations. However, there are some benefits mainly related to the morbidity of the procedure to laser ablations. I don't know if
you have to be careful not to reinvent the wheel sometimes, because we had this story of the selective amygdalo-hippocamectomy more than 30 years ago, and we knew that when you remove in the medial temporal epilepsy only with mesial sclerosis, you remove only the hippocampus, you don't cure the patient. The results were very bad. So you have to remove these areas plus the parahippocampal gyrus plus the temporal pulsar, more or less the temporal lobectomy, even if we don't give this name, to get a good outcome in temporal lobe epilepsy. So we'll see, but I am not so optimistic.
Right. And again, I think I share this skepticism from Dr. Chauvel as well. Again, as long as we have a very well-defined epileptogenic zone that most likely is met by invasive evaluation or by other means, but we really need to make sure that we have a very well-defined demarcated epileptogenic zone.
The basic question is briefly that if you have a small epileptogenic zone, a small resection is okay, but if it's more extended, it's logical that it doesn't work. So that's right.
Very good. Let me proceed here. And all the above is the answer. In question number 4, which two of the following risks are not lower for laser ablation of epileptogenic lesions than for open resection? Number 1, infection, hemorrhages, and infarction, deep thrombosis and CSF leaks, incomplete resection and worse seizures in patients with large lesions, injury related to metal implanted devices such as vagal nerve stimulators. Dr. Bulacio?
I really I will get your help because you're the expert on this one. I will.
Let's see the answer here.
Two answers. Okay.
Incomplete resections were worse seizures in patients with larger lesions and injury related to metal implanted devices such as vagus nerve stimulators. Very good. Let's proceed. So this is what we perform for this patient. This is an intra-op picture. We have also the luxury to have an intra-op MRI suite. So this is an intra-op picture showing the final placement of the laser probe. What we did here is we removed the SEG electrodes and we follow exactly the same tract of the L prime electrodes that we record the seizures. And this is a picture, a tomography of the laser ablation procedure. Here are the lines of the temperature. We know once the temperature reaches approximately more than 65 centigrades, there is a permanent depth in the tissue, and this is what we see. So this is a very well-controlled lesion. This is what makes the difference between laser ablation and a radiofrequency ablation. A radiofrequency ablation is a completely blind procedure. We cannot estimate what will be the volume of the resection. With the laser, we can make the ablation bigger or smaller, and we can see that live second by second with new images being updated almost instantly, almost at the same time. And here's the final results of the laser. This is a post-op MRI showing the
Could use this.
the ablative areas here that has probably approximately 1 centimeter in diameter, 1.5 centimeters, located in the mesial frontal areas, exactly in the locations of the L2 to 4 prime contacts where we record the seizure onset. Any comments from the group? Okay. So our outcomes early in 2015. So we have 1 year, no seizures since surgery as on a single antiepileptic medication at this point. EEG showed no epileptiform discharges after 1 year, and he's back in driving a motorcycle, his passion.
That's such an elegant and beautiful focused surgery that you were able to craft after a detailed operation. And I would submit that if you added your resection to the multimodal imaging that you did, it would line right up and be exactly that. It's beautiful. Congratulations.
Thank you.
Okay.
Case highlights.
Okay. Very good. This is nice. So cases highlights. So as a take-home message, I would like to emphasize that laser ablation is a feasible alternative to open craniotomy for epilepsy surgery in some cases, having the discussions that we have with Dr. Chauvel comments. Advantages include low morbidity and brief hospital stay, usually 24 hours. Indications include small, deep epileptogenic zones, and laser ablation is especially advantageous in patients with high perioperative risk, giving them access to epilepsy surgery.
Thank you. And thank all of you for being with us through these 2 cases. We'll take a 5-minute break and be back with the 3rd session. Thank you.
Thank you.